through our WebEx platform and our YouTube channel of Universidad Pontificia Bolivariana. Have a warm welcome to this second day of the first virtual symposium of home care for patients with congenital heart diseases, an integral look. This is Claudia Jimena Meneses. I'm the head of communications department of UPB. On behalf of Universidad Pontificia Bolivariana and Fundación Cardiovascular de Colombia, we want to give you a special welcome to this important event, which we have been developing since yesterday with prestigious presenters, experts in the topic or in the subject, both from Colombia and overseas. We have been developing different topics regarding coronary diseases in children and in neonates, and we also thank them for sharing their knowledge and for participating in this experience, which contributes to a better quality of life for our patients. Let's remember our symposium is framed within the PROMESA project. PROMESA is the home monitoring and education program for patients with complex congenital heart diseases developed by Universidad Pontificia Bolivariana and Fundación Cardiovascular de Colombia. This project operates in order to implement an educational system to teach the carers of patients with congenital heart diseases to keep them at home during a specific period where they have been discharged after any intervention or procedure. So without any much to do, we want to introduce Dr. Victor Raúl Castillo, who is the chairman of Fundación Cardiovascular, so that he opens this second day of our symposium. Welcome, Dr. Castillo. Claudia, thank you very much. I want today to give a special welcome to all of the audience in this second day. I also want to thank Universidad Pontificia Bolivariana and all the cardiopediatrics team in Fundación Cardiovascular de Colombia for the organization of the symposium. So this second day, which we are opening today, is very important within the framework of the PROMESA project. And as Claudia mentioned before, essentially is an educational frame for the integration between the family and the institution in order to have the better care and monitoring possible for these patients with complex congenital heart diseases after the surgical procedures are managed at home. So we want to welcome you all to this second day. We hope you enjoy it. And I'm completely sure that because of the quality of the presenters and the topics to be addressed, you will certainly have a good advantage of it. Again, my thanks to the university and the cardiopediatrics team of Fundación Cardiovascular. Thank you very much. Well, Dr. Victor, thank you very much for your kind words. And with this, we open the second day. Now we invite Dr. Javier Castro. He is a surgeon and physician from El Bosque University and subspecialty studies in pediatric surgery in Fundación Cardiovascular de Colombia with Universidad del Bosque. His main activities focused on different cardiopathies and heart transplants in children. Besides, he Well, good morning, everyone. Thank you again for being with us today. This is the second day of the Promesa Symposium, where we are telling our experience, and different lectures about the care for children with congenital heart diseases. To start today, we have a conference by Dr. Maria Constanza Basto, The Reality and Expectations of Children with Congenital Heart Diseases. Maria Constanza is from Bucaramanga, is a physician and surgeon from Universidad del Rosario and subspecialty studies in cardiothoracic surgery from Clover University in Paris, a fellow for reanimation in the Necker Hospital in Paris, and she leads the cardiovascular anesthetics process in Fundación Cardiovascular. She's an associate professor in Universidad del Bosque and Universidad Militar, magister in bioethics, coordinator of the bioethics committee of the Association of Anesthesiologists. She's a part of Medicines Sans Frontier, providing care for many children with congenital heart diseases worldwide. Constanza, welcome. Thank you very much, and thanks to all the participants who got up early to participate in this second day. We're going to begin with a presentation which may not be some medical but more ethics, and where the expectation from the medical standpoint, is when we take a child for a procedure, and in this case to a complex surgery in palliative stage. Allow me a moment while I set up the presentation. So when we talk about expectations and reality, it's like the memes. And that is so much in fashion. I always expect something, but we normally get something different in reality. And that's a typical case. But when we talk about children with complex heart diseases, we may approach to this. We expect a sunny day and a nice beach. However, it seems something grayish and full of inconveniences. And that's what we were taught yesterday in the presentations by the psychologist. So why this occurs? Because mainly in medicine, uncertainty is something that has a particular role, a special role. Despite we always want a good outcome for the patient, sometimes it's difficult to foresee which patient will have a complication or not. So what happens when you take a kid to a surgical procedure, or simply when we get a child for hospitalization and consultation with cardiologists? Evidently we have a diagnosis and they begin a clinical management, either ambulatory or as an outpatient. And if this patient is susceptible to have a surgical procedure, either for correction or for palliation, to improve his physiological condition, as was explained yesterday by Claudia and Dr. Fajardo. So after we decide that the patient is actually a candidate for the surgical procedure, the patient is taken to surgery that was chosen. There will be a post-operatory, and I mark these two stars over here in the decision-making and the post-operatory stage, because these are the most critical times to make a decision for the patient and the complications that may arise in the post-operatory stage. However, when we analyze and we see the patients, and that's when the Promesa project is born, when we go to follow-up, what happens to the follow-up of patients? And that's where we that's what the expectations go away from reality. When children have a particular characteristics. With an adult, when you make a decision, you talk to the patient, you explain the possible risks, complications, you discuss the procedure, and the patient gives the consent to be taken to surgery, or to say, no, I don't want any kind of surgical procedure. I just want medical management. But when we deal with children, unfortunately, they don't have the neurodevelopment to be autonomous, especially these patients who are babies. So the decision-making process has to be in a joint manner. It's not only jointly between among the physicians, but between the physicians and the caregivers. And sometimes in caregivers, the decision is left only with the medical staff or the healthcare staff. So how do we make that decision? So it's very easy because we do it on our day-to-day work. We have a diagnosis, we analyze the risk factors, and those risk factors may be clinical and statistical. Why do we say that? Because we are based on literature to make decisions. That is to say, we collect data, and now that we have big data, so we collect all of this information, all of this data. They are analyzed, and we sort out according to the patient's characteristics. Then we analyze comorbidities associated to the patients, and finally we have the prognosis, and that will lead us to say the kid is a candidate or is not a candidate for surgery. So when we talk about the risk factors, normally these are factors that we may not modify. That is to say, the child is born with characteristics that perhaps are unmodifiable. So these are the main risk factors in hypoplastic left heart syndrome. So we have low weight at birth, or if they are premature, or if they have chromosomal anomalies. Unfortunately, those risk factors cannot be modified. The type of deficiency, tricuspid or bicuspid deficiency, so these are very difficult factors to modify, and the need of sorry. So based on these risk factors, we are filling up with reasons, or we are feeding the balance for the decision making in risks. Something that we need to consider also in these single ventricle patients, or patients that are not candidates for a first corrective surgery as we would all desire. So we need to take into account that besides the complex cardiopaties, they are also associated to any kind of chromosomal deficiencies or any congenital predispositions. So these factors do not always come on their own. So that leads patients to have a worse prognosis. And other alterations that are not usually preventable, that may lead to risk that cannot actually be approached from the surgical standpoint. Neurological commitment is perhaps one of the things that is considered most in comorbidities. We know that 75% of single ventricle patients or patients with any kind of obstruction in the outlet tract have a certain base neurological commitment. The compromise, they are born with some kind of a neurological alteration, perhaps by the decrease in the blood flow during the fetal stage. Therefore, the saturations, the oxygen saturations will be decreased. And the alterations are not only morphological, but also physiological when they have seizures or edema. And another thing to be considered is the presence of previous cardiorespiratory arrest. So taking all of this, we feel the balance of risk against benefit, and we present the patient to surgery. That makes us, in this year up to September, we haven't been able to take patients to some kind of a surgery, and because of multiple factors, 10% of these factors that were taken are not candidate to a surgical procedure. And so what else do we notice? In the expectations, we would always like to have a certain percentage of success of 100% in our patients. And that's something that all of us who work in healthcare, what do we want? We want that all of our patients do well. And the goal that we have is like that. And that's the reason of our joint work. Something else that we would also like is to compare ourselves with the rest of the world, to benchmark ourselves. So that is to say, if we take a procedure in Latin America, we would like to have our outcomes to be comparable with results or outcomes in North America, in Europe, in Asia, well, with these large centers with congenital heart diseases or centers with more experience in this field, in these procedures. But when we talk about success, specifically, what is surgical success? And that's something that surgeons actually like. Immediately, the first slide, when there is a morbidity, mortality, the first figure they present is survival. We want all of our kids to live alive, but also to do well. So survival to discharge and survival of 30 days after surgery. We also see other kind of issues that occur, for instance, reintervention, which normally occurs due to bleeding, or if there are any kind of residual defects, that means that the patient is taken again to surgery or taken to a procedure by intervention cardiology. Also, we consider morbidities. We evaluate the weight gain in the patient, motor development, and language development, and schooling. So, in general, we know that these patients have fine disorders in the development of a language and cognition, learning disorders in Spanish in Latin America, if we're talking about the language in general, and in the cognitive processes, which include numbers and mathematics. When we say we want to benchmark with the rest of the world, we want to see the statistics from the rest of the world. And this is a little chart we have about survival. This is the SPF with the procedures for HLHS. And we say, wow, that's wonderful. Mortality is 14.3 in a very high complexity surgery. Being positive, they had a survival of approximate 85%. But if you see the European databases, they had a survival in a normal procedure of 77%, which is also a very good survival rate. And now what is our reality? When we see, let's study, let's see what is going on with us and what is happening to our patients specifically. And this is what we generate with the Promesa project. Actually, there was a meeting for left heart hypoplastic when we started to see what was happening specifically with our patients' survival, we decided to go beyond. We decided to see what was going on with the monitoring, with the follow-up. So the survival rate was not that bad. It was 77% at 30 days after Norwood surgery, which is perhaps the most complex surgery that we may have. And the follow-up expectation, we had this. We had a survival near 80% during the interstage period. That is to say, between the first palliative surgery, in this case Norwood, to the second one, which is the partial pulmonary bending. So this is what we wanted to find. That was the expectation we had. But in our reality, it was not that good. We realized the mortality in the interstage was in 42%. So in the graphical Kaplan-Meier plot is very significant. And you see, wow, 42% in this case, near 50%. So what we have to do, or why this is happening? So in the internal analysis are similar in the first part. We can say we are not the same, but we are very, very close to first world countries. So what happens in the interstage period? Why our expectation does not go closer to the reality we are seeing? And when we see the risk factors in the hospital, we realize there are risk factors that are not going hand in hand with the surgical or the medical management. And these are, or we have studied proved these socio-economical factors that have influence on these patients, and racial factors, and also weight gain factors. So all of this will have an impact in the quality of our patients. But why do they talk about ethnicity or race and the socio-economical factors? So as we all know, We are living this during the COVID times. We know that in the US, for instance, patients that have died more of COVID have been Latino patients and interstage 1, even in the Black population, because these people have a larger number of comorbidities and they have less capability of access to health services. And not only for these complex cardiopathies, so the deficit of people, sorry, the possibility of a patient accessing surgery is about 30%. 16.9 people in 2010 lost their lives due to surgery, conditions that require surgery, but they couldn't reach a place where they would get that surgery. And that affects socially because they not only die and we lose years of life and social contribution, but it also generates disability. And disability is joined to the social cost in healthcare provision. So as we can see, this is not only the problem of complex congenital heart diseases, but healthcare in general in any part of the world. So what happens to us, to countries that have a low economic income? So it's more difficult to provide this attention to all patients. So from these figures I showed about the interstage, so what are the expectations and our reality? Our reality did not reach our expectations. So with the Promesa project, we said, okay, if they cannot come to us, we will go to them. And that's where we discuss what we mentioned yesterday. What other things are normally not considered when making decisions? We take into consideration risk factors, the clinical status of the patient, the prognosis. But other things we need to take into account is the quality of life. The quality of life is one of the hardest things to define, particularly in these patients because they cannot talk. So we are going to define the quality of life. So if the child is going to have a quality of life, we as physicians and the parents have to decide that. And also, as I mentioned about disability, disability means to have a high social burden and a high family burden. So almost half of the parents will stop working to take care, to meet the needs of their patients or of their children. And it's not only that, but also all the consultations, rehabilitation processes to have a child that when grow can reach at least a basic functionality level. When we talk about quality of life, we're talking about the fears of the patients and the healthcare personnel. And this fear, so to say, to this combination of a child that has, for instance, a neurological disability and a cardiac disability. This was a study made by Knowles et al. With healthcare personnel and carers to evaluate the quality of life of the patients with complex heart diseases. And if you realize the vision of the parents and the carers is very similar with regards to the quality of life of those patients. So these patients or the parents, sorry, not only learn from them, but we also learn from the parents. That's so when we as physicians make a decision, we are acting as a bridge between the patient and the family, and we're also being a bridge between the system and the society. So when we make a decision, we not only approach from the facts, or from the clinical facts, but we also need to consider all of the values and the duties we have with the patients. Why values? Because as I showed previously, the patients, because of the conditions, may have an influence on the prognosis and in the quality of life of those patients. And that decision ultimately will have an influence on the patient's future, but also in the future of the society. So the decision to whether to operate or not has an impact on the family, has an impact on the patient, and it also has an impact on the society because it's how we take the kid in the best conditions possible in order to have a school life, for instance, or to have a life close to normal, so to say. What kind of things do we need to avoid when we talk about medicine in this particular cases because these are kids with a high comorbidities. And these are things we need to take into account to avoid dystonia and therapeutical futility. So these interventions that are not helpful at all, we need to avoid them. So what happens if we cannot take them to a surgery, to a surgical procedure, and then we have a conflict between the expectations and the realities? There is a moral conflict because I would like the best benefit for the patient, but unfortunately, due to some clinical aspect or oftentimes because of different conditions, they cannot be taken to a surgical procedure because there are no carers or because there are these conflicts with the families. And in the clinical context, we know that is not unusual. So when we say that a patient is not a candidate for a surgical procedure, it doesn't mean we're going to abandon the patient. We need to continue a clinical management, focus on improving the patient's comfort and also accompaniment to the patient and the caregivers. There is one thing that we often neglect, which is the healthcare staff. They generate in these patients with high complexity generate some moral burden. We usually talk about the parents or the people in charge of the child, perhaps uncles, grandparents, or the social services. But these diseases also have an impact in the decision making and in the moral conditions of the healthcare staff. So as conclusions, we know that our expectations are different from the reality that we live in the local system and the reality if we compare with the rest of the world. However, in order to decrease that gap between expectations and reality, it is necessary to be aware of what happens at the institutional level to be able to compare and to provide better care, to realize where the problem is, and if I can find as a physician or as a group or as a healthcare entity, I can have an impact on the survival of these patients. When there are dilemmas in medical management, but not all of the situations can be managed with surgical or clinical management. There are dilemma situations. We need to apply ethics, and with the help of ethics, help us to review the context where the patient is, not only the patient with multiple pathologies, but the global context of the patient. And something that I will not get tired of repeating, we cannot forget the emotional impact caused by the care of these patients for the carers, for the society, and for the healthcare personnel. Now I have a phrase by Marsh, a British surgeon. He says, there are 3 months are needed to learn how to do a surgery, 3 years to know when to do it, and 30 years to know when not to do it. Thank you very much. Yeah, I believe the last part of the sentence, knowing when not to do a surgery, I believe that's the hardest part to learn in our practice. Now we continue with Dr. Álvaro Durán. He will talk about complications in the interstage period and why do kids come back to the ICU? Why are they back again in the ICU? Álvaro is from Santander. He's a physician and surgeon specialist in pediatrics from Universidad Industrial de Santander, a specialty in cardiovascular intensive care pediatrics, and he's currently the director of pediatric cardio surgery at the ICU in Fundación Cardiovascular. He has more than 20 years of experience in the care of the more complex cases in pediatric cardiovascular cases and the care of patients with heart transplant and with ECMO. Also, he's a trainer of subspecialist in pediatric cardiovascular surgery. He is my professor, and he is an active member of the clinical research team in our institution. Álvaro, welcome, and it's a pleasure for us to have you. Well, Claudia, you are talking too good, too well about me today. Thank you for all of these compliments. So let me allow me a moment to share my screen. Content. That's perfect. Okay, first of all, I would like to give a special thanks to Javier Castro for the invitation for this first symposium of home care with children in complex congenital heart diseases, and also congratulate him with his enormous commitment to the children in this Promesa project. Besides, I would like to thank Laura Carolina, my resident in the intensive care unit, who has helped me in gathering information for this presentation. So, for starters, HLHS represents 5% of cardiopaties, but however, unfortunately, sorry, they represent the largest mortality. We talk about 25% of mortality in this first week of life. However, in spite of how ominous that can be, without treatment, 90% will die within the first month. Many centers report up to 70% of survival. And as Maria Constanza said before, even in some cases with very good quality of life, which is what we want to achieve with these complex babies. Within the sequence of attention of care for these patients with hypoplastic left heart, there are three surgical times, three surgical moments. There is a first stage, which is at the time of birth. These are children that after birth are subject to a procedure, a cardiovascular high complexity procedure, which will be in pre and post-operative of period that you would say, oof, okay, I made it. Right? But that's not so true because there is an interstage phase later, which is where most of mortality occurs worldwide. And even there are centers that talk about even 43% mortality. And that makes you frustrated because all of this effort for this first interstage and the patient dies either at home or even in the hospital waiting for the second stage, which, as Constanza mentioned before, are the stages that have less complexity, and that is to say, the Glenn and the Fontan procedures. But of course, they also die, but it's much lower the rate than in the first interstage. Interestingly, this has been studied in recent years, and one of the motivations for Promesa is that with strict care, that mortality, there are even reports that mortality goes even down to zero, but even decreases in significant manner, regardless of the condition of the baby. But beyond that, if we make or if we provide a good care, we can prevent these patients from dying. And the intensive care issue is still very reactive in this interstage scenario. So we have low cardiac output and compromise. When they come for something more elective, it's something that needs to be detected with monitoring at home, and we can have an early intervention to avoid those complications. So this issue about the risk factors have been studied in recent years in a very judicious manner. And something particular in this HLHS pathology particularly is that it has become the standard of quality in the cardiovascular services. Many of you may remember that 15, 20 years ago, the standard of cardiovascular care were the transpositions. And we have improved a lot, we got the guidelines, and now we have the left hypoplastic, and that's a good thing because there are very good guidelines for left hypoplastic heart. So we have been finding some risk factors in the last years, in recent years, sorry. One of them is nutrition, which is very, very important. It's a determining factor. Let me explain this. Not only on patients that have heart failure, but just by the fact that they don't get this normal weight is determining factor. And that conditions other issues, other cardiovascular issues, even infection problems. Also, the low weight at birth is a predisposing factor. to have a poor prognosis during the interstage, not only Norwood as such, but also in the interstage gastroesophagic reflux. It needs to be corrected either with medications or surgically because this also contributes to malnutrition and other issues. The feeding the feeding way, we need to ensure that the baby eats even with gastrostomy or with a tube because we know that worsens the prognosis. So this weight gain that is well identified and documented in the literature. So this issue of the strict weight control is significantly important. Another interesting issue is that even all these kids are in perfect conditions, they never have an ideal weight at the time of surgery. They get close, but with the surgery, the weight decreases. In the first normal procedures, they decrease, and then in the best case scenario, there is a regain. That's something that we want to get, the regain of weight, to see whether they have at least their ideal weight. So if they gain 20 or 30 grams, that's very important before the discharge of these babies. Um, Here we have the feeding ways at the time of discharge. That's a publication. Well, I don't remember the study, but at the time of discharge, we see that some patients are eating orally, feeding orally, others by PO and G, others being fed with a combination of a tube and gastrostomy. So as the kid reaches the interstage and the gland, there has been a gain, but you can see many of them still end up in these conditions. And sometimes we don't like to have the babies with the gastro or with the tube, but that aspect is fundamental. Why? To gain weight so that the kid has a better development, not only on size, but also psychosocial and other kind of development. Interstage, different interstage factors, anticonvulsant medications. If the kid is receiving that kind of medication, there must be a base neurological condition that may predispose to multiple events. For instance, to have a poor muscle control or the effect of anticonvulsant agents as such, which have an influence on the neurological status. Unscheduled re-entry. The standard, for instance, in our context and in many centers in the world, I believe, is that babies re-enter because they got very bad. We want them to re-entry, but they go in a scheduled, rigorous way, but not when they are dying. Because when they come to re-enter in this shock, that will affect their prognosis. The extended stay, it has to do with all of these factors. The kid was for a long time in the unit. It's because surely there was a comorbidity or an effusion problem or an unresolved anatomical problem, and that affects the interstage. Ischemia and surgical technique, obviously the times are longer. If there was an issue of residual ischemia that's severe, anyway, the technique for healthy against the median Norwood, some people are more in favor of the healthy Norwood, at least in the first stage, in the immediate postoperatory. These patients will have less risk of ischemia. However, later on, the mortality and the survival practically get equal. But in the interstage, it's important to highlight that ischemia is significant depending on the surgical technique. Arrhythmia, ventricular dysfunction, if we can diagnose them early, that's better. And the same for residual lesions. It's very important for the patient at the time of discharge and during the follow-up that we are certain that the residual lesion, either functional or anatomical, we know we have to try or to treat them aggressively, so to say, because any residual defect will ruin in the long term the procedures with these patients. Something that was mentioned by Connie, I believe, was this issue that we see in this slide is the day-to-day reality in Colombia, the monitoring by different teams. But this is obvious here because of the system. At the end, we have 4 or 5 echoes. Nobody is actually in charge of the patient. That's very, not only for heart conditions, but non-heart conditions as well. Also, diseases are also pertaining to infancy, and that will have an impact on the kids because of the frailty, the poverty, the geography, location. That is a problem for us, and it definitely has an impact, and it has been proved. About the Hispanic population, hopefully it will not be about the race, but the social issues, and because of the geography, because these studies are made in northern countries or in North America and in Europe, perhaps Hispanics have less possibilities of access to healthcare, and the limitation to healthcare services. That's a real burden in our country. Because these kids, we should be doing a gland on them after 4 or 5 months of age. However, the authorizations for surgery take more than 2 or 3 months. And in these 2 or 3 months, somebody would say, oh, that's a little time, but that's a lot in the case of these patients. Secondary effects of medications, we mentioned something about it in anticonvulsive agents, but some frequency we see patients with uh, severe complications or medications where we don't have adequate dosage for pediatric patients. And in my head, I have more than 5 or 6 patients that have come with an arrest or a blockage or kidney failure because of secondary effect of these medications. And there are some premonitory symptoms. It's like the sixth sense that we have developed. For instance, irritability, distress, diarrhea, fever, cyanosis. So all these premonitory symptoms are a key, as I say. So that tells us, oh, we need to rush to the hospital because if they evolve, the kid will end up maybe in ischemic distress, maybe caused by circulation, diarrhea conditions, the shown to be clogged, fever vasodilates the patient and increases consumption. So any of these things that the baby present has a significant impact. The causes of death, unfortunately, in the interstage, I'm mentioning here our statistics and some publications in the literature that have something in common with our statistics. As unknown causes, the kid suddenly dies at home and the cause is unknown. So that's one cause, sudden death as such, but oftentimes is perhaps there is bronchoaspiration or neurological issues, or when the probe. Sometimes the kids are discharged with the nasogastric tube, and there may displace massive and arrest, sudden death, pulmonary chronic disease, catheterism, severe hypoxemia, arrhythmia. Is it predictable? Well, Dr. Ganayam says that ultimately it's predictable because what has been studied that despite there are all of these conditions that are delicate, neurological issues, residual issues, malnutrition problems, this doctor managed to reduce mortality. Well, even though it's not zero, she has decreased death in a significant manner. Perhaps we could decrease it, hopefully below 12%. That will be the next goal in interstage mortality to ensure, obviously, that the growth and development of the babies, and that leads to a good quality of life. The goal is to have live, nice, fat babies, but if their brain is a mess, or if their family condition is a mess, as we will not be contributing to a society. So we may improve mortality, but these 3 things are very or equally important. These are some slides that show, well, in general, when we have made the studies about the strict monitoring at home, the general trend is actually this strict home monitoring reduce mortality. and we are convinced it is like that, and it benefits the patient. Tony mentioned this. This is in the guideline that came out this year. These are pathologies that if we have them, we have some residual factors or feeding issues. We know they are critical risk factors. So what do we do? What do we do? We need to live with these factors. We need to do follow-up, and that's the key to have ultimately these kids in a better condition. When we address or when we come to these children, we need to make an analysis. What is happening to these babies? It's not that difficult. It seems not to be that difficult. Obviously, we need to know what we are talking about, that HLHS, what can be happening. We may have an inefficient QPQS. I'm even more concerned about the lower than the higher. So in terms of a small QPQS, there may be a severe hypoxemia, but it's easier to treat them. Obviously, the shunt size has an impact, but surgeons are very rigorous about the type of shunt, the length, and so I know surgeons are very strict on this, and in order to avoid obstructions, for instance, on the shunting. Obstructive residual lesions, as I mentioned before, are very important to be considered. Sometimes we don't see them. Sometimes we have the catheterism and we don't see any gradient. And there is an interesting study with MRI where we see an RVW where this factor predicts poor quality that will favor that this ventricle will not work. So how to study the patients in a very rigorous manner to know that they don't have an obstructive lesion. Systemic vascular resistance alteration by disease, the presence of heart failure. So why the heart failure? There are many factors, but we focus on the heart, the obstructive lesions, the ventricular functions, atrial functions. So all of these are considerations that we need to keep in mind. When we have the patients coming in the ICU, there are many things to be analyzed. We have highlighted them, the poor gain on weight and size, which is the minimum denominator. Sometimes they are so swollen, but they are not gaining weight, but gaining water. The assessment of the heart failure is important. Also, if there is a low cardiac output, infection and shock, like in any patient, but is much more serious to manage a shock in single ventricle condition with the right single ventricle, and besides having an infection or a residual defect, that's a significant challenge for these patients to define whether it is hypoxemia or overcirculation, kidney failure. 30% of heart output goes to the kidney, so any alteration in the cardiac output gives origin to kidney failure, and the kidney, the only way to improve it is with perfusion, and we're having inotropic support that will worsen the status of the heart, of the condition of the heart. So this is complicated to manage, and sometimes we have to report even to early dialysis, not to force that heart. Dehydration, neurological issues, and so on. Neurological issues are complicated because even in the prenatal stage, we don't always assess, and there are clear studies that say after the fourth day, even after the fourth day, they may have deficiencies. So these kids have a very important handicap, even from the prenatal stage, that needs to be considered. This is a paper by Javier Castro et al. Just to emphasize what we have mentioned before, we are not just reinventing the wheel. This crazy is that we have more deaths than in other places, so that's what we need to work on. And another very important thing is lost patients. That's a paper from Laura. This is a headache for the country, and we need to pay attention to this not only from the health providing institutions, but from the national government, because this is unacceptable. It means that children do not have an adequate follow-up. And this makes you think, why are they lost? Is it because they die? Because that's the concern we have. We suspect they may be dead, or they are in a so poor condition that there is nothing to be done. So follow-up needs to be worked significantly in the country, because all of this effort and all of these resources is not worth to lose all of these patients. These are some data by from Dr. Claudia Flores, a co-worker, which facilitated me this data. When you see, well, we get excited with this. Out of 66 normal patients, 51 survive at 30 days, but there are 11, 11 kids that die hospitalized in the interstage. So we have a problem either in choosing the patients or residual problems. So this is a topic to analyze. And this figure of 11 death at home, it has something that can be prevented with home monitoring. She finds that coarctation, the coarctation is the main issue as a risk factor in mortality. Feeding disorders, you can see, is very frequent, and that's also something that needs to be worked on. So as conclusions, we can say that this disease or a clinical condition with a high morbid mortality interstage, and you would, where we talked about, okay, yeah, we made a Norwood and that's it. No, the most complicated part is the interstage, and the interstage forces us to have a more interdisciplinary approach, to work with the teams, with home monitoring, with all of the cardiology team and everyone involved in this procedure. High losses interstage, something needs to be done to rescue these patients, and how to do from now on not to lose these patients. The high mortality, as I mentioned before, is concerned. Interstage in intra-hospital is very high. And what we are doing now, the home monitoring programs, and in the ICU, my take-home message is that we need to do a follow-up in the ICU. We need to work more on the sense of doing scheduled things. And this is it from my side. Thank you very much. Well, thank you, Alvaro, for your presentation. Now, it's an honor for me to introduce my friend, Dr. Vanessa Lopez Lopez. Dr. Lopez is from Spain, from Barcelona, a physician on the Universidad de Barcelona, anesthesiologist from Universidad Autónoma de Madrid, has studies and training in extracorporeal circulation and ultrasound, pediatric urgencies, and hospital management. Currently, Dr. Lopez is the head of the anesthesiology and cardiovascular ICU in the Necker Hospital in Paris. Vanessa has also been involved in multiple training programs in pediatric heart surgery all around the world. Besides, she is a member of the Spain subaquatic subaquatic hockey team. Well, hello. Well, good afternoon. Well, in Spain, good morning to you. Thank you for being with us. I'm pleased to participate in this symposium. I want to give some notes about palliation and what can we do for our patients to have the best outcome and as quick as possible in the best conditions. In single ventricle, there is a great variety of lesions. It can be actually a single ventricle, a smaller ventricle that contributes little to heart output, ventricles of the same size, but that may present several anatomical lesions, and several anatomical lesions that hinder I'm sorry. Um, and as I was saying, some similar ventricles but with lesions that do not allow the proper communication as having a single ventricle. Management will depend about the pulmonary flow that the neonate has and also the dependence on the doctors and the flow. If the pulmonary flow is increased, the patient will have a congestive heart failure, and then we need to have an intervention with a banding, which is to have a Gore-Tex calibrated band around the pulmonary artery. Patients with doctors dependent circulation, the initial management in the first hours and days of life is done with prostaglandins, and we would also need to think about substituting the doctors with an anastomosis or a Blaylock shunting. And then we have patients with left ventricle hypoplasia, which usually have mitral atresia. With doctors dependent circulation, they require neonatal very complex surgery, and there are several possibilities. The classic Norwood, which is to join the pulmonary artery to the aorta and provide pulmonary flow. Norwood, healthy Norwood, which is done through an anastomosis of the single ventricle to the pulmonary artery. There are teams that have developed hybrid systems with catheterism and surgery. And as a curious thing, in the Necker team, they make modified Norwood, which is to replace the doctors doing a banding on the two pulmonary arteries and dilate the aorta and the atrial communication if necessary. That this kind of surgery has the advantage that the initial postoperatory is much less important or less harder for the neonate because there is no aortic clamping and it's easier to balance the pulmonary and the systemic flow. On the other hand, it has some inconveniences with the retrograde pulmonary perfusion through the aorta, with the small ascending aorta, and scarce coverage of pulmonary arteries. So what are the prognostic factors in these patients? Well, the type of cardiopathy we have seen it can be uh, in neonates. We don't have uh, the same type of severity when they have two ventricles or left heart hypoplastic ventricle, or when they have a single ventricle with right anatomy. The comorbidities, Maria Constance Ours already presented a little bit about comorbidities, low weight, prematurity, maternal fetal infections. There can also be the base condition of the patient may have a lot of influence. For instance, if it has been fasting or if there is a suspicion of pulmonary status will be affected or compromised. Evidently, then the surgical outcome if we manage to have a balanced systemic pulmonary flow with a good function, good ventricle function, and other postoperative complications that may delay. So what kind of interventions can we have? We optimize the preoperatory status. In this, we have a significant role to be done is to operate the patient on the proper time. We don't need to wait for obstructive attrition. There is a pulmonary compromise that may cause a pulmonary edema or heart insufficiency. The treatment of comorbidity also to take the patients in the better conditions to the OR. Then, as I said to anesthesiologists, I say reanimation begins in the OR. From the induction, we need to think about reanimation. We need to take care of the volume, of the volemia, the inotropes, hemoglobin, and the management of the systemic and the pulmonary flows. And then a postoperatory, an active postoperatory reanimation. We need to start thinking in the OR on how to extubate the patient as soon as possible. And, other interventions include prevention of infections. For instance, in patients when we are very invasive with them, we may have the three-stage keys in all catheter connections to remove catheters as soon as possible. Then respiratory physical therapy in order to extubate the patients as soon as possible. Also motor rehabilitation, nutritional support, as has been discussed previously, to have early enteral nutrition when the patient's conditions allow to do so. And then we have the comfort for the patient, the drainage, the dry drainage to avoid noises, silent respirators, for instance, high frequency ventilators. We need to avoid or minimize the noise. And here I have a picture of some decibel capture. When there is a lot of noise in the room, the ear comes red, so that we realize there is a lot of the noise level is high, and we try to decrease as much as possible the noise in the machines. Another important issue is the care after discharge. As Dr. Duran mentioned before, there is an interstage period in all palliations, which is very important. And they need to take care of the patient after or the patient at birth when the surgery comes. Then to give early discharge, but also we need to follow the care at home. So we need to have a close monitoring, weekly monitoring. Here in our program, the patients come once per week to external consultations in the hospital. There is a significant logistic support with nurses during all of the interstage period that allows monitoring or a close monitoring. The enteral nutrition either by tube or nasogastric tube, and the optimization and the global condition of the patient that contributes to the psychomotor development of learning, and that will help us to have a good quality of life for the patient, which is our main goal ultimately. So as conclusions, we may say that in general, when we talk about palliation, we'll talk about an heterogeneous group of patients with different prognosis and evolution in accordance to the base pathology, and also in accordance with the surgery, how it goes, whether there are complications or not, and the post-operative evolution of these patients, in order to optimize our patients so that they can have a positive evolution and a quick and optimal discharge, or living the reanimation is a multidisciplinary work for all caregivers, and also the support that needs to be given to parents. One of the some of the factors that have been published in the literature are the strict monitoring of care after discharge or after the procedures. Well, thank you, Vanessa, for your presentation. So animation and intensive care begins from the OR because that's important. It has an impact on the care, on the preoperatory, because it forcefully will have an impact on the interstage and the postoperative and the discharge of the patient. Thank you very much for your presentation. Now it is my pleasure to introduce the next presenter. The next presenter is Kevin Lever. He is a nurse, more than 15 years of experience in intensive care, pediatric cardiovascular intensive care. He's in charge of looking after patients in the knee care hospital, pre and post-operative patients in heart surgery, ventricular assistance, and ECMO. He's an instructor, a trainer in nursing, paramedics in the hospital, and he has participated in the formation of intensive care teams for cardiovascular pediatrics in several parts of the world. Mozambique, Cambodia, among others. Kevin will talk about, I'm missing something very important. He's also a member of a benefit association, which provides support to families and children that are born with a complex congenital heart disease. Kevin, thank you very much for being here. Thank you very much for logging in. You're welcome. Bien, gracias por invitarme. He trabajado en el Hospital Necker por 15 años y hemos tratado de llevar a los pacientes a la mejor condición para la cirugía. Y bien, vamos a hablar sobre dos niveles, el nivel físico y el nivel psíquico. Hablamos de los programas, ayer hablábamos de los programas de monitoreo en casa. No tenemos esto en el programa Necker, como poder llegar a casa con la posibilidad o las mejores condiciones que necesiten los pacientes. Bueno, en cuanto a los primeros puntos, son los problemas de peso. Varios oradores han hablado de ellos. Esto es un factor crucial porque va a ayudar a determinar el tiempo de la cirugía, además de determinar el tipo de cirugía. También ayudan a determinar los resultados o el tipo de bypass y los resultados y el resultado de su cirugía, que es bastante importante, ¿sí? También va a tener repercusión sobre el desarrollo, el neurodesarrollo o la mejoría posterior del paciente, y se ha mostrado este ha sido un problema significativo entre los niños y puede tener un impacto sobre muchos elementos, y también es un factor difícil de manejar porque hay algunas cardiopatías, algunos pacientes en estas cardiopatías, que requieren mucho más ingesta de calorías que otros pacientes. Entonces es algo difícil de manejar. Además, se puede tener algún tipo de síndromes o de trastornos horarios que contribuyen a una larga estadía en la UCI, entre la hospitalización, yo he visto que es casi, se presenta la mitad de los infantes que requieren suplemento, ya sea con tubo o con sonda nasogástrica, y eso es muy importante porque también contribuye al, al tiempo, a la extensión de tiempo. Entonces los padres tienen que estar involucrados con la enfermera y las nutricionistas para suministrar la leche fortificada o ya sea con botella o a través de alimentación por seno, y esto va a afectar también la hospitalización. Otro problema que enfrentamos con los pacientes son los problemas infecciosos, porque la infección puede retrasar la cirugía y puede sobrecargar el sistema. Es importante entonces, para lograr esto, tenemos las vacunas. Normalmente, si no se tiene una cirugía previa, se puede tener 15 días antes del procedimiento y un mes después de la primera cirugía con bypass. También utilizamos el palivizumab, normalmente para la mayoría de bebés, que evita la broncodilatación del recién nacido y no tiene un impacto y se puede utilizar, se pueden vacunar. También tenemos las vacunas contra la gripa que se aplican a los pacientes en las UCI y también a los padres, y eventualmente se aplican también a los hermanos si hay consentimiento de los padres, para realmente evitar que cualquier virus se pueda transmitir a estos pacientes. Otro punto a revisar con los padres es con la higiene básica. Es algo que puede ser un poco obvio, pero se presenta o hemos encontrado, por ejemplo, en la presente situación de pandemia, uno se sorprendería de ver cuánta gente no tiene claro las normas de higiene. Entonces tenemos que asegurarnos de recordarles el lavado de manos, el cambio de ropa frecuentemente, y todo ese tipo de cosas. Y hay que estar seguros de que estén bien con esos procedimientos, que la familia, los hermanos o el entorno recuerden eso, para eliminar cualquier foco posible de infección. Hablamos también del ambiente en el estadio oral, desde el nacimiento hasta los 18 meses de edad, de manera que sabemos, que todo lo que nos toquen o llegue a sus manos termina llegando a sus bocas. Todo hay que mantener todo limpio. Es importante no volverse tampoco paranoico, pero también hay, sino porque esto puede ser algo difícil para la familia. Hay que encontrar un equilibrio entonces entre ser protectores, pero no ser sobreprotectores con los niños, porque ellos deben vivir su vida lo más normalmente posible. Obviamente tenemos a los padres y la familia que están involucrados en esto, y el médico familiar, el médico de cabecera, la enfermera, con los cardiólogos y todas las personas involucradas que pueden tener contacto con el paciente. Otro punto a nivel físico es la monitorización. La monitorización y todos los factores importantes es la saturación de oxigenación, la monitoría cardiológica también, en la saturación, en el cardiólogo también, encontrar los signos de degradación de la función cardíaca, y es enseñarles a detectar lo más pronto posible esas señales de fallas o de degradación de la función cardíaca. Las personas involucradas en este nivel son el cardiólogo, el médico familiar, la enfermera, y los padres. Los padres están capacitados en cuanto al manejo de los dispositivos para el monitoreo, por ejemplo, para el uso del oxímetro. Entonces pueden, si tienen esa capacitación, pueden observar diariamente esas cifras de oximetría y saber, aprender cuáles son esas medidas normales y viables de saturación. O el siguiente punto en cuanto a los factores a nivel físico, para mí, tiene que ver con el desarrollo psicomotor. Este es otro gran factor. Puede haber muchos factores. Por ejemplo, en una estadía larga en la UCI pueden afectar diferentes etapas. Es importante entonces, como son factores importantes para que el paciente lleve una vida lo más normal posible. Por ejemplo, los reflejos arcaicos, el desarrollo de habilidades motrices finas. Es muy importante también preservar esas habilidades y es algo que tal vez no sea tan obvio como parezca, pero en muchas, usualmente la estadía en la UCI no protege mucho esas funciones en el desarrollo psicomotriz. Obviamente los padres están involucrados acá también en las terapias psicomotrices, en el acompañamiento de fisioterapeutas. Es importante recordar que estamos cuidando a seres humanos en formación, no son seres humanos completamente terminados. Esto me lleva al siguiente punto, al nivel psíquico, en cuanto al desarrollo intelectual, en las habilidades relacionales de los niños y el aprendizaje escolar, por ejemplo, la lectura, las matemáticas, todo ese tipo de cosas puede ser influida por las diferentes hospitalizaciones, esa estadía larga en la primera etapa de paliativa, y también puede disminuir ese desarrollo, especialmente por las particularidades de las cardiopatías. Por ejemplo, pueden ser afectadas las habilidades de aprendizaje de matemáticas y de lenguaje, por ejemplo. Entonces los padres deben hablar con los maestros, también con terapeutas de lenguaje, si hay algún tipo de trastorno que pueda tener impacto sobre las habilidades del habla, y también está involucrado la parte nutricional. Los puntos finales sobre el nivel psíquico son factores que no se deben olvidar, que son los factores psicológicos. No es algo obvio, no solamente afecta a los pacientes, sino a los padres. Pues ya con los pacientes ya son más maduros, hay que hablar con ellos, hay que saber qué está ocurriendo con ellos. Es importante para encontrar qué ocurre, que tenemos que advertirles, prepararlos para la cirugía, porque pueden estar tal vez aislados de los padres y puede haber algún cambio. Esto es más importante para los pacientes ya mayores. También tenemos ese involucramiento antes de la cirugía. Sabemos que la cirugía puede ser algo traumática. Hay que prepararlos para que sea más fácil su aceptación, esa posición entre los hermanos. No olvidemos esta parte de los hermanos, porque creo que es importante y que la presencia de un hermano enfermo no vaya a causar resentimiento entre los demás hermanos. En la parte psicológica es muy importante. También las personas involucradas, entonces tenemos al psicólogo, las enfermeras, los cardiólogos, perdón, que van a explicar cómo se va a desarrollar la hospitalización para que los padres puedan llevar esos mensajes a los hermanos y de nuevo, perdón, me olvidé un poco sobre lo que mencionaba María Constanza anteriormente de, en cuanto a los defectos congénitos. Ay, se puede tener la contribución de los pacientes en diferentes asociaciones para que compartan sus experiencias en cuanto a los procedimientos y la hospitalización que han vivido y el manejo que han tenido a nivel familiar y social. Bueno, como conclusión podemos decir que la preparación de un niño para una cirugía cardíaca es un trabajo extenso que puede incluir alrededor de 10 personas, pero el paciente realmente es el centro de todo. Hay que tratar de ayudar a coordinar a todo este grupo para lograr un mensaje óptimo. Tal vez es diferente donde se tienen programas de monitoreo en casa, pero pues, en mi experiencia este equipo es algo ideal. Pues este es como decía, un ideal un poco difícil de lograr, pero en mi opinión debemos tratar de buscar el bienestar de los niños que están a nuestro cargo. Y en mi opinión pues, es importante tener este paciente bien preparado que va a ser dado de alta más rápido. Muchas gracias por su invitación. Gracias, Kevin, por tu presentación. Gracias por estar con nosotros. Es importante reconocer que este es un esfuerzo de equipo y el equipo de enfermería es la columna vertebral del cuidado intensivo para estos pacientes. Well, Kevin, thank you very much for your presentation. It's important to remember that the work on these patients is a teamwork, and nurses are the backbone of the intensive care units. So right now, to me, it's a pleasure to introduce Dr. Norman Silberman. He's a worldwide authority in pediatric cardiosurgery with congenital heart diseases patients. He has an extensive bibliography. He's a world-renowned professor. Es un placer contar contigo, Norman, y esperamos ver tu presentación hoy. Muchas gracias por estar con nosotros hoy y acompañarnos. Buenos días y muchas gracias a ustedes por la invitación. Aquí son las 6 de la mañana. Estoy acá. Este es un importante esfuerzo de tenerme en las primeras presentaciones. Yo quiero hablar en primer lugar hoy sobre las correlaciones ecocardiográficas y anatómicas en el periodo interestadios y qué debemos buscar. Yo soy profesor en la Universidad de California, profesor emérito, en la Universidad de Stanford. El trabajo que estoy haciendo va a ser presentado en md1.world.com, www.md1world.com. Allá van a ver el libro que estoy escribiendo y un resumen de esta presentación que se va a incluir en este trabajo. Para algunos que no estén familiarizados con esto, vamos a ver las correlaciones que tenemos entre las técnicas como la ecocardiografía, la tomografía computarizada y la ecocardiografía. Yo soy un ecocardio, yo soy especialista en ecocardiografía y lo que yo hago es ver las imágenes y darle al equipo, bueno, porque este es un equipo que ya tenemos, y vemos las diferentes características de la enfermedad. Aquí pueden ver la aorta con los vasos que van hacia el cuello y vemos la aorta ascendente Vemos acá ese flujo coronario y vemos la radiografía que las muestra. Este es un ventrículo derecho, el ventrículo izquierdo es más pequeño en este ejemplo patológico, y aquí, por ejemplo, tenemos un ventrículo izquierdo pequeño y una masa ventricular porque hubo tanta isquemia en la parte del ventrículo que se calcificó. Y aquí tenemos un gran ventrículo izquierdo con una alestosis cardíaca presuntamente por las características de isquemia que se alinearon durante el desarrollo. Vamos a ver cómo se ve una coartación. Aquí vemos un esquema con una pequeña aorta ascendente, la aorta grande, el ventrículo izquierdo hipoplástico y el ventrículo derecho que mantiene la función. Y la primera operación es anastomizar la aorta y la arteria pulmonar alrededor del corazón. Aquí vemos la aorta ascendente, la arteria pulmonar que es desconectada, y luego se le aplica un shunt. Aquí está el shunt, y aquí aplicamos un parche, un homoinjerto o un pericardio que se coloca en esta abertura, y la aorta queda, se le hace una incisión, y la arteria pulmonar también se le hace una incisión acá en el extremo y se le aplica el parche, y aquí se tiene un egreso completo desde el ventrículo izquierdo. Durante la segundo estadio, el shunt se retira. Bueno, pero que este shunt está siendo reemplazado con un pequeño conducto desde el ventrículo derecho hacia las arterias pulmonares distales por medio de un conducto. Y esta es una modificación del concepto Norwood original. En el segundo estadio, lo que hacemos es tomar las arterias pulmonares y se trata de hacer un shunt, y se coloca en las venas cavas una anastomosis en la vena cava superior, en las arterias pulmonares. Entonces el cuerpo superior puede ir hacia las arterias pulmonares que están ligadas para evitar que el flujo vuelva al cuerpo. Y entre la primera hacia la tercera etapa tomamos un conducto de córtex, se hace anastomosis en el lado inferior de la arteria, perdón, en la arteria pulmonar, y ahora todo el flujo desde el cuerpo superior y el cuerpo inferior va hacia los pulmones, y el ventrículo derecho cumple la función del cuerpo. Me disculpo si es algo demasiado básico para ustedes, pero no perdamos a las personas que no están familiarizados con esta operación. Aquí tenemos un corazón de un paciente que no sobrevivió al Norwood en el estadio 1, y pueden ver la aorta nativa que hicimos la anastomosis como en esta foto. Lo que podemos ver es el conducto de homoinjerto que se le hizo anastomosis a través de esas suturas a la aorta, y pueden ver el saco pericardial, y este es el remanente de la comunicación entre la aorta ascendente y el tronco pulmonar. El tronco pulmonar surge del ventrículo derecho, y pueden ver cómo se mantuvo el shunt. Aquí hay un pequeño tubo en la orejuela para perfusión. Obviamente el paciente falleció en el postoperatorio. Lo que buscamos en el procedimiento de Norwood es, en primer lugar, se debe mantener, perdón, lo que buscamos es la comunicación auriculoseptal, y vamos a seguir viendo esta área porque se han presentado pacientes que desarrollan alguna obstrucción en esta región del septo. Buscamos la anastomosis aórtica proximal. Este es lo que suministra el flujo sanguíneo a la aorta hacia las arterias coronarias. Buscamos la aorta distal en cuanto a coartación, porque esto se va a extender alrededor y en el 70% de los pacientes con síndrome de corazón izquierdo hipoplástico va a van a presentar coartación de la aorta y esto es un riesgo para pacientes con un mal pronóstico. Regurgitación tricúspide, también la válvula tricúspide va a funcionar como una válvula mitral y esta función es bastante importante porque la insuficiencia mitral es un problema a largo plazo que lleva un pronóstico de disminución. Entonces, esta regurgitación tricúspide, si la reconocen, es un factor importante. Tenemos que ver también la función del ventrículo derecho. El ventrículo derecho es el ventrículo sistémico, entonces tenemos que evaluar cómo está funcionando. Vemos también el tamaño del shunt. Aquí estamos viendo el septo auricular, vemos acá el shunt Blalock-Taussig, la vena cava superior, y aquí es el septo auricular. Todo el septo auricular ha sido, se le ha hecho una excisión y se ve aumentado en este paciente, incluye el área del ventrículo, en la parte posterior del septo auricular ha sido extendido hacia el limbo de la fosa venalis y aquí se puede reconocer. Aquí es la foto que les estaba mostrando antes e incluso de manera temprana en la operación se está evaluando y se sigue viendo ese septo auricular buscando su adecuación. Tenemos la aurícula izquierda, derecha, la aorta descendente, el ventrículo izquierdo pequeño y aquí está el ventrículo derecho. Entonces, si vemos esto, les va a dar que la válvula mitral está presente en este ejemplo y el engrosamiento endocárdico, que son características muy significativas en la anomalía de válvula mitral. Y la función, vemos a la anastomosis de aórtica proximal. Aquí estamos viendo la morfología de la anastomosis de aorta proximal. Vemos el ventrículo derecho y la válvula Casa cercana a la aorta. Con anastomosis proximal podemos ver la sutura, la vena cava superior que está aquí y la aorta ascendente con anastomosis hasta este vaso de aquí. Aquí tomamos las etiquetas para que puedan ver la anastomosis, cómo está las suturas colocadas en paralelo de una manera muy bella y la colocación del conducto. Vemos la anastomosis a la aorta proximal, que es muy importante. Y aquí en otra foto vemos lo mismo con la aorta cercana y el conducto de homoinjerto, y aquí podemos ver la comunicación entre la aorta cercana y la vieja aorta para suministrar el retroflujo a las coronarias. Es algo muy, muy importante. Este es el procedimiento de Sano, este es el doctor Sano, que trabajó con la Universidad de California en San Francisco, y vemos acá el vaso, la aorta cercana, la neoaorta, aurícula derecha y ventrículo derecho y el shunt de Sano. Aquí voy a quitar las etiquetas para poder ver mejor. Vemos algo de la aorta proximal. Podemos ver también que hay una pequeña insuficiencia aórtica aquí. Aquí vemos una regurgitación tricúspide por el momento y aquí podemos ver en los colores, vemos el ventrículo derecho y la aurícula derecha, vemos una fuga a través de esta válvula y vemos la neoaorta desde el ventrículo derecho y la arteria pulmonar, la anastomosis, que es proximal en la cámara aórtica proximal, y a medida que nos movemos podemos ver que hay una insuficiencia aórtica, que es realmente una insuficiencia aórtica que parecía pulmonar, pero vemos esta insuficiencia aórtica, insuficiencia mitral hacia el ventrículo derecho, que se utiliza solamente para las presiones arteriales pulmonares. Y vemos acá el shunt de sano. Aquí está el origen del shunt de sano con esta laceración a través de la pared del ventrículo hacia las arterias de las ramas pulmonares. Vemos acá el shunt con anastomosis hacia el tronco de las arterias, hasta las ramas de las arterias, perdón. Acá tenemos la función del ventrículo. Podemos ver que el ventrículo derecho está funcionando bastante bien, se contrae muy bien. Aquí está en otro paciente que obviamente sobrevivió esta primera estadio. Aquí vemos el shunt que ha insertado el doctor de seno y vemos el flujo. Y aquí vemos la neoaorta a medida que entra en el shunt de sano, y vemos en la ilustración una pequeña cantidad de insuficiencia, no tanto como una regurgitación tricúspide, pero vemos una disfunción del ventrículo. Podemos ver en otra presentación, frente, parte superior y parte inferior. Vemos acá el ventrículo derecho, ven el flujo hacia la neoaorta, la anastomosis en la vieja aorta por la arteria coronaria, y vemos el arco aórtico hacia la aorta descendente, y pueden evaluar la adecuación de la anastomosis, al igual que el shunt. Esta es una vista que utilizamos para revisar, bueno, la vemos en diferentes formas. En cuanto a la regurgitación tricúspide, es muy importante. Si la reconocemos en la operación, es algo significativo. El cirujano se le dirige a realizar una reparación del anillo tricúspide. Vemos acá la regurgitación tricúspide y vemos acá lo que va a ser el seno coronario, que está arriba del ventrículo derecho, y esto está, este reflujo hacia, de retroflujo hacia el seno coronario, que puede causar el problema. La regurgitación tricúspide es muy importante de ser evaluada y de vigilar su progreso continuo, porque si hay una regurgitación grande, el ventrículo derecho empieza a funcionar mal, y esto es importante. Una de las razones importantes para este paciente, para la falla continua de la cirugía. Y la regurgitación se puede utilizar para evaluar la función. Sabemos que el corazón tiene sístole y diástole. La sístole es larga, la diástole es muy acortada. Y aquí tenemos un corazón entonces con una muy buena función diastólica en un paciente recién nacido. Vemos acá la función cardíaca, y este es un paciente con regurgitación tricúspide, y podemos ver acá la sístole es muy larga y la diástole, el flujo a través del ventrículo, a través de la válvula tricúspide en este punto es muy corto. Entonces la relación de la sístole sobre la diástole, aunque está por debajo de 1, a medida que aumentan los latidos, la frecuencia cardíaca, una relación por encima de 1.6 veces, es más sístole que diástole. Este fue un estudio del doctor Roberto Zenari en el Journal de la Sociedad Norteamericana de Ecocardiografía en agosto del 2009, y esta del doctor Friedberg, y de quien les habla. Vemos la relación entre sistólico y diastólico, las relaciones sistólicas y diastólicas normales en pacientes normales o pacientes de control, comparados con los pacientes con síndrome de corazón izquierdo hipoplásico, y pueden ver la relación acá. Este es un tema muy importante que se puede medir simplemente mediante flujo Doppler. Se puede ver acá entonces la sístole y diástole en esta forma. Ahora, en estudios más recientes, realizan rastreo con eco en el ventrículo, que es, o los instrumentos que se utilizan más comúnmente hoy. El doctor Nuncia Borrelli y sus colegas hicieron este informe y aquí hay la diferencia entre cambio efectual en pacientes normales y pacientes que han fallecido y pueden ver cómo el RBF ha cambiado. La, la fuga sistólica, cómo ha afectado a los pacientes normales comparado con quienes han fallecido por esa falla en la función planar, los cambios en esto parece bastante constante en pacientes de control, pero ha incrementado en los pacientes que han fallecido, que van a un área en que se puede rastrear la disminución de esa fortaleza y vemos la tasa de fuerza, cómo se mantiene o cómo ha aumentado en estos resultados. Podemos ver también la fracción de eyección. Acá tenemos un paciente normal, diástole, al igual que en la sístole. Y aquí podemos ver la diferencia entre sístole y diástole. En la auricular derecha, el ventrículo izquierdo diminuto que no funciona. Y cuando vemos las diferencias entre estas estructuras, este ventrículo difícilmente se contrae y tenemos acá una regurgitación tricúspide. Esto nos habla mucho de las cosas que son un problema que tienden a ser abordados al momento del shunt de Glenn. Ahora también nos lleva a un mal pronóstico de los pacientes que fallecen en el interestadio de este procedimiento. Esto puede ser hecho técnicamente, si lo pueden ver en la cuantificación semiautomatizada. Pueden ver la posición del ventrículo y se pueden medir cosas como el área de la cámara sistólica y diastólica. Pueden medir que también se contrae este ventrículo en esta dirección, el esfuerzo, el margen de la pared marginal, etcétera, y se pueden obtener unos valores normales y anormales y cuáles son las correlaciones. Entonces, este es un aspecto muy importante al revisar la función ventricular, que no puedo dejar de enfatizar que es importante en estos pacientes. Aquí estamos viendo un espécimen cuando abrimos el conducto de un paciente, de otro paciente que no sobrevivió. Y podemos ver en el conducto hacia el área de la aorta descendente, se puede ver una coraza que está presente. Este es un problema de coartación que no fue abordado adecuadamente al momento de cirugía. Aquí podemos ver cómo se ve un paciente, cómo se ve en la coartación. Y aquí vemos una serie de imágenes que nos muestran esta situación, una técnica Doppler que utilizamos que muestra el arco aórtico. Hay una coartación que está claramente orientada. Aquí está el arco aórtico y pueden ver que hay una obstrucción del flujo sanguíneo. Y este es un problema bastante significativo porque los pacientes que tienen una válvula tricúspide con fuga o una válvula aórtica, neoaórtica con fuga son una de las razones por las que no les va tan bien a los pacientes. Tenemos que ver esto intraoperatorio y estas lesiones son continuas y se van a volver más significativamente a medida que aumenta el flujo sanguíneo. Aquí vemos una vista de la anastomosis Vamos en el área de la coartación cerca del arco aórtico. Aquí hay una lista normal del arco aórtico donde vemos que el aórtico, perdón, no presenta obstrucción. Y aquí tenemos un paciente con una obstrucción muy, muy grave. Hay otras técnicas y aquí tenemos un ejemplo de una reconstrucción de CT scan que muestra la neoaorta, el arco aórtico acá en esta región y el área de la coartación antes de la aorta descendente. Y cuando vemos la aorta descendente, lo que estamos buscando es a nivel del diafragma, en un procedimiento de Norwood debido al shunt, hay un flujo retrógrado a medida que la sangre pasa al shunt de Blalock-Townsend, que en este paciente la aorta se ve con un pulso arterial, con un flujo en diástole y hay flujo progrado al inicio y al final de la diástole. Y aquí tenemos ejemplos de pacientes que presentaban obstrucción en el arco aórtico y si comparan estas con este, no solamente están fuera de carácter, sino que la tasa de llenado y vaciado es diferente. Aquí el llenado es muy rápido y el vaciado está comprometido. La diástole aquí con este flujo es rápido por la inflamación en la aorta. Aquí vemos esta ola y aquí casi esta es una estenosis aórtica, perdón, una coartación de la aorta moderada a leve. Y pueden ver el flujo distal a medida que perdón, a 16 milímetros de mercurio, que es una coartación sustancial, como lo hemos visto acá. Lo siguiente que vemos es el shunt. Este es un ejemplo de un shunt Blalock-Townsend. Este es el angiograma que muestra el shunt yendo hacia las arterias pulmonares y aquí vemos el shunt que vemos desde la base de la arteria iluminada, vemos aquí la aorta iluminada hacia las arterias pulmonares y nos ofrece esta área. Ahora con el flujo en Doppler a color vemos la aorta ascendente, la arteria pulmonar izquierda y la inserción del shunt. También pueden darse cuenta que hay un estrechamiento en la arteria pulmonar derecha en esta área. Obviamente esto va a afectar el flujo de sangre hacia las arterias pulmonares derechas y puede causar una disminución de la perfusión del flujo. Estas son el tipo de cosas que podemos evaluar. Obviamente esto se hace de manera continua porque esto no existe al momento de la cirugía. Aquí lo vemos muy hermosamente. Aquí vemos el shunt desde abajo. Vemos el flujo sanguíneo que viene del shunt hacia las arterias del tronco pulmonar. Ya no lo vemos más, pero este es el tipo de cosas por lo que aplicamos o queremos ver para aplicar ya sea un Blalock Townsend o un shunt de sano. Ahora vemos el shunt del procedimiento de sano, vemos la válvula tricóstida, la neoaorta, y esta es la salida del ventrículo derecho, y aquí está el shunt de seno, y el flujo del shunt de seno que es acelerado. En nuestra institución ponemos una válvula contenedora en esta área, y modificamos el procedimiento, y pueden ver el flujo que sale hacia la arteria pulmonar aquí. Esto limita la cantidad de flujo y es la razón de éxito de la cirugía. También vemos la aorta ascendente y las aortas pulmonares y aquí tenemos un angiograma que muestra las arterias pulmonares al igual que la fístula, la formación de fístulas miocárdicas. Aquí está la aorta ascendente y las arterias del tronco pulmonar que están presentes ahí. Y por último, vemos el arco desde arriba, vemos todo el arco, la aorta, que es un signo indicador de flujo incremental. En este paciente vemos la anastomosis. Ven aquí, estas son las suturas que aparecen regularmente. También parece estar bien reparado. El calibre de la arteria está bien, pero hay un poco de obstrucción cuando vemos con el flujo de color. Y esto es un área de preocupación. Este es un paciente con una obstrucción peor. Podemos ver que no solamente hay un cambio en el calibre, sino que la aceleración del flujo se ve más proximal a esta área. Entonces este paciente está en coartación, este paciente necesita ser evaluado. Y por último, tenemos que ver en el abdomen, en la aorta, en la neoaorta, y acá tenemos un ejemplo de insuficiencia neoaórtica. Esto es un indicador de que tenemos que hacer algo en la válvula pulmonar. Aquí tenemos otra vista a la aorta proximal con insuficiencia aórtica y pueden ver, además de la función, además la función no es realmente satisfactoria. Entonces voy a detenerme acá porque ya he sobrepasado mi tiempo. Cuando uno evalúa otras cosas como los shunts de Glenn, podemos ver acá un poco, también podemos ver el procedimiento de Fontan. Vemos acá la cánula de la vena cava superior con el shunt de Fontan, con la vena cava inferior hacia la vena cava superior, y vemos la anastomosis inferior también. Y aquí es un paciente que tuvo fenestración con el anastomosis superior e inferior. Este es el área de fenestración. Y vemos también el Fontan desde abajo. Esta es una de las características que vemos en el paciente. La mayoría de estos pacientes son evaluaciones mucho más sofisticadas con scans de tomografía y con resonancias para definir y decidir cómo abordar esos pacientes. Aquí está la vena cava superior e inferior, y lo que vemos aquí es para descartar malformación por este shunt en la vena cava inferior. Y aquí podemos ver un paciente que se le puso un shunt en la vena cava inferior y vemos la aceleración del flujo. Cuando el paciente inspira hay mucho retorno venoso, entonces el pulmón está succionando sangre debido a la aspiración. Y esto se ve menor en la expiración. Pueden ver esto en un periodo de tiempo. El paciente respira silenciosamente, y pueden ver que hay varias diferencias en el flujo, tanto en el flujo regular como en el flujo en Doppler de color y en el paciente durante la expiración. Bueno, solo me queda agradecerles por su atención y esperamos. Bueno, aquí en esta área, en el Fontan, tenemos la regurgitación tricúspide persistente que continúa haciendo mala la función. Bueno, déjenme terminar mostrando que lo que ocurre con el Fontan que falla, pero se puede ocurrir en cualquier momento. La regurgitación tricúspide, dilatación, forza, o hace que el Fontan falle, la dilatación ventricular también. La desincronía hace que falle este procedimiento. Y esto va avanzando según la rueda. Hay alteración papilar o posición muscular, prolapso tricúspideo, asentamiento alterado de las válvulas, obstrucciones en las válvulas, en los vasos, contracción sistólica disminuida causa falla. Esto causa también esfuerzo alterado, disfunción diastólica, la dilatación auricular, arritmia y regurgitación tricúspide. Todos ellos conspiran para hacer fallar el frontal. Bueno, me queda agradecerles por su atención y a Javier por invitarme y que continúen trabajando con los hallazgos ecocardiográficos en estos pacientes con cardiopatías complejas. Muchas gracias. Muchas gracias al doctor Sindelmar y gracias por compartir con nosotros esta conferencia tan didáctica. Thank you. Muchas gracias. We continue now with our program that we have Dr. Ana Fernanda Unive. Ana Fernanda is the Academic Vice Chancellor of Universidad Pontificia Bolivariana. She's a physician, Master in Education and Prevention of AIDS, Master in Prevention of Job or Hazards, psychologist of Pontificia Universidad Javeriana from Cali. She is currently a research and professor in the School of Psychology. Ana Fernanda, welcome. She's going to talk about risk factors and protection, social skills in healthcare professionals. Well, thank you very much, Claudia. This is a very important event for us because we are trying to share all of these experiences around the Promesa project. You can see my screen, right? Yes, we can see it. Yes, we can see your screen, yes. So I'm going to talk about some fundamental aspects related to risk factors and protections in soft skills in healthcare professionals. For us, it's important for Universidad Pontificia Bolivariana, from the Clinical Psychology Research Group, we have worked on the fundamental elements to which healthcare professionals are exposed. As we know, the job of healthcare professionals to reduce risk and complications of patients, in this case in children with congenital heart diseases, is fundamental in order to continue working on the well-being of the patients and of the workers as well. As we know, the roles of healthcare professionals in their training and the day-to-day work are not only oriented to research and know the different elements managed around an issue or a disease as such, but additionally, from that research and qualification, they are looking for the diagnosis that allow to communicate to the patient and also to analyze the different situations and issues. When we address these elements, they have to do with the formal training, but there are other demands for healthcare professionals, which on many occasions are not trained or developed on time, and they may cause consequences both on the healthcare professionals and the people with whom they relate. And for the healthcare workers, for all the communication exercises, we need to solve a lot of situations related to diagnosis, but also to accompaniment to the patients, to the families, to the friends, and also to the colleagues, particularly when there is a particular situation of death or complication of the case or any remission that allows us to work as a team. So soft skills are important in our practice. During the symposium, we have acquired different skills. We have expanded our knowledge about congenital heart diseases in children. However, it is very important that during these exercises, we also identify those soft skills or those capabilities of our professionals to provide in a better manner or in a more humanized manner our service. That is why soft skills are defined by different authors, and I have included certain definitions which are centered on these capabilities, dispositions, or skills that are fundamental to develop a task properly. There are two important elements in the relationships. For instance, a pleasant tone of voice and obviously to generate a pleasant experience despite their condition. But they also mentioned two elements for the strengthening of those soft skills. One has to do with knowledge of oneself, knowing limitations and potentialities in order to be able to accompany others in their processes. These skills are developed from the infancy by training and development, and others are acquired during our profession. A significant element we have included, as Carlo Bermejo says, that we need to consider those feelings generated by our interventions. Sorry. Yes, something that is very interesting in these authors state is how us in these relationships with the patients, with the families, with our surroundings, we have human warmth, the closeness to our patients, kindness to our patients. So how do we learn how to manage our feelings, not to hide them, but to adapt them to the patient situations and help make the proper decisions. That is why different studies establish specifically with regards to the user satisfaction, there are behaviors within the healthcare professional. So we see factors such as initiative, creativity, teamwork, and also empathy. Uh, Out of the criticism made to healthcare professionals is that sometimes we are too technical when saying things, but those technicalities or technicities are the strengths of our work. What we are doing more and more is to translate our discourse into the language of the patients. With the Promesa project, we are trying to facilitate the communication so that we can work in a closer manner with the professionals. Also, we have important communication skills. How not to say things so bluntly, but things that may be clear to us, but others may interpret in a different manner. Much more when we are related to other systems, for instance. That's why um, this generates a ranking for services provision for the users that we are working with. So how is this? How is the healthcare professional evaluated in terms of service provision? So in this research, 80% has to do with the attributes. The patients identify that the healthcare professionals looks after me, reviews me, answers my questions, relieves my pain, and provides comfort despite of the situation that may be living. Another fundamental element, which is important, has to do with respect, a positive attitude, and patience. This doesn't mean that we are going to provide a denial of reality for the patient, but with this respect for the patient, and feeling like the patient, we can achieve an empathy that allows a significant synergy in the relationship. Similarly, we can find that it doesn't mean that we need to be smiling all of the time because we need our emotions, but some elements are arising in terms of showing affect, a smile, visual contact that has been established as a main element in the medical attention in terms or the attention from healthcare professionals. So this visual contact allows me to say, I'm interested in you. I'm not just interested in your clinical history, but I want to establish a good contact with you. By smiling, people do not appear to be more polite, but they are also perceived as others as more competent. So that means professionals, when they smile and they are more polite and emphatic, the users evaluate them as having more competence. Because oftentimes we say, oh, he's a good professor, he knows a lot, but his teaching is not very good. So the healthcare professional is like that. He's very knowledgeable on his subject, but his treatment towards the community or towards his colleague is not very good. That's why, in terms of how can we develop those social skills or those soft skills for the healthcare professionals, we associate it mainly to the psychosocial risks to which they are exposed. One of the main risks when there is exposure not only to chemical elements or to biological elements. However, there are psychosocial risks that have been identified in different occupational diseases in different sectors. I mentioned some here. One is most over strain on the muscles, usually identified in nurses or in nursing assistants or the another which is associated to skeletal muscle disorders. One of the main symptoms on the skeletal muscle system is fibromyalgia, which is associated to the polyfunctionality of women who are working at home and at the job site as well. But this is also presenting in the male population. So all of these muscle issues, irritable colon syndrome, things like that are associated to the digestive system, associated to the stress burden. Other thing we have found associated to healthcare professionals have to do with job stress. Mainly, I want to reiterate that these professionals, in general terms, healthcare workers, 50% have skeletal muscle diseases, and 33% in nervous disease disorders. That is significantly anxiety disorders. And we see here that between 20 to 33% of the job force feels high levels of stress. And this stress has to do with the relationship with people. And if we identify all of these situations in the pandemic to which we are exposed this year, these manifestations are increased and they have been approached by different research in this year. But mainly how during these new job dynamics, the other labor, familiar, and leisure spaces are affected. But people have a little bit more of time. They work more, but they have more time also to exercise or to rest. But one may say, well, I believe our healthcare professionals, I don't believe we have more time. We have more tension, more stress, but we continue with our commitment. So one thing is to respond temporarily. We have high stress levels and we try to manage them, but ultimately it has significant consequences. Perhaps we don't feel it right now, but over time, this job fatigue accumulates. So in this sense, we start to analyze how the processes by incorporating new technology can facilitate these things. And that's part of our project, is how with the relationship with our carers, we can generate not only a quicker response, but also to provide a diagnosis or a response to professionals and the support from telemedicine, because that's also being managed from the psychological areas. So in the project, we are working on how we provide technological elements for the caregivers, for the care of our patients. If we identify in the context of medicine, we see that telemedicine is creating a very important component and some significant soft skills, because before it was more, the treatment was more visual, but by incorporating telemedicine, we see the increase of consultations, particularly in cardiovascular diagnosis. Again, there is a significant contribution on in terms of how to do that accompaniment. We, we did it with the conviction in the project that we may facilitate accompaniment to the patients even before the pandemic. We can identify some of the specialties that have increased the telemedicine service. That is why it is important that we are able to identify those stress symptoms to which this demand is associated. Because there are different emotions that appear in our healthcare professionals. When we begin, we start with fear, uh, for preserving the life of our patients, but also some surprise. When you see the pictures in terms of the qualification systems, we have surprises on the breakthroughs of research and the interventions. Also, we have moments of frustration, sadness, because we don't get the outcomes we desire or the therapeutical goals or the intervention goals that we desire. So based on this, it is important for us to establish everything that has to do with those symptoms uh, that help identify because it is fundamental that we identify our own health conditions, frequent headaches, sleep alterations, which are very frequent in healthcare professionals, some excess to decrease anxiety, for example, food anxiety or psychoactive substances, also excess of exercise to try to decrease irritability, stomach disorder or digestive disorders, and so on. So some papers identify a risk, a psychosocial risk in healthcare professionals are those psychological demands. And not only there is a physical component, but also psychological demands on our professionals. And there is also some insecurity in terms of a job continuity. Sometimes this necessary support is not present, and also with self-esteem. And that has an influence, and it allows for us in complicated times to manage different situations. So we are not exempt from losses during these processes. And during those losses, that's where life is more assessed or more reviewed, and also our professional processes. But there are also significant gains in this. So during the grief stage, we need to be able to identify both the professional and the personal feelings and understand the situation so that doesn't become something of habitude, because this will have an effect on the future. During that exercise, we generate a concept and we work permanently from psychology, which is health in general, specifically when we talk about mental health, is not only to work from the thought, because we know psychology has significant elements from the standpoint of mental health, but we want to generate a process for physical well-being, mental well-being, and social well-being, which allow to have a connection or proper relationships that allow us to manage these stressful events. Not only soft skills that allows us to manage stress, communication, empathy, but in many occasions we have negotiation skills, decision making, which is very important for the patients, also the development of resilience elements. To do that, in the interest of time, we're going to go over this quickly. One of the concepts we manage from soft skills, we have this construction that we do around those strategies that improve the quality of life, not only for the patients, but also for the healthcare professionals. So first of all, we strengthen, and that is part of the outcome we want to share from the Promesa project. We want to strengthen the knowledge, the technical, professional knowledge with regards to a punctual situation or a disease, that knowledge decreases the level of anxiety and the tension of being able to control all of the all of the difficulties. So knowledge is fundamental to that, and that's part of the cognitive component, which is important to manage. Additionally, we need to manage effective education skills. Effective education will allow us to contribute to what we call the psychological health, where we are starting to have elements where we don't have anguish in a reiterated manner, where the stress is decreased, and our personal and self-assessment improves, and we learn how to manage these situations and those emotions that are appear normally. So as we develop more skills as professionals, and our soft skills will contribute to that. Also, we need to generate areas or spaces where we can work on our life projects and social influence. So our professionals, we have spaces to recharge both on physical and psychological energy. That is why social networks or interpersonal networks are fundamental, where we have support networks in our families, in our co-workers, besides these networks of knowledge that allow to explore with our patients and to highlight these emotions to which we are subject. And finally, being able to establish everything that has to do with alternative or complementary processes, not only to focus not only on self-realization, but including well-being, which includes management of leisure time, which is not only to keep it on a study, which is a typical behavior of healthcare professionals, but being able to do other activities. Now, during the professional spaces, we are generating recreation, healthy eating, and exercise activities, and that's important. Uh, it's important to have these spaces to strengthen ourselves as persons. So there is a lot of bibliographic material available um, to take individual and group strategies and institutional strategies, and also on the social level that allow us to keep strengthening us professionals and developing those soft skills that will foster a connection with our patient with an assurance that the process will continue outside of the clinical space, and this will favor everything that has to do the therapeutical adherence of our patients to the different healthcare processes. Well, I want to thank you for this time, and let's continue sharing this experience in the symposium as a result of our research project. Thank you. So we have a mortality of 3% in this period, but that's a mortality we consider has a lot of bias, especially by that percentage of, sorry, sound is breaking. It's mute. So the idea of this call for research was to state a problem for the project was to identify these elements that were so important because on many occasions we believe that when we are taking data for a clinical study or a research project, we simply sit down and write 260 variables for a particular problem, and we believe that the larger the database, the more information we will obtain. But from the statement of the problem and the goal, we start noticing which are the measures that we are going to adopt. So from that point of view, so we couldn't have a whole pool of variables without having a clarity on what will be the goal of our work. One of the problems we visualized was a limitation of the parents with regards to these diseases because of the lack of knowledge. These are diseases which are not well known in the community, and lack of communication that may occur between the healthcare professional and the parents, and insufficient education with regards to the disease, generating doubts on the course of action, the barriers to access, the lack of knowledge of the system. As we know, our health system has a lot of administrative conditions, and since these patients require a follow-up, obviously patients and carers are sometimes overwhelmed by a lot of terms and conditions to comply with. And there is also lack of knowledge in the follow-up over time that we need to have on the patients. This lack of knowledge from the primary healthcare system, where they don't have a clarity with regards to the management of the patients. So all of this derives in mortality in children with complex cardiopaties, the potentially lost years, high morbid mortality in patients, the cost for the healthcare system because they demand high cost. There are studies that these sort of patients may represent up to 10% of income, but 60% of expenses of patients discharge over a specific time. And if we go to standards to compare with international centers, so we design a methodology where we have a mixed approach with the application of qualitative and quantitative research. Qualitative research was focused more on those concepts of education for the parents and social relationships of the patients with all stakeholders in the system. And from the medical standpoint, we evaluated the the baseline and the fine and the end line in the project to evaluate the impact, evaluating also the clinical characteristics of our patients. All of this with a year of preparation and 2 years of follow-up of the patients. So we had as fundamental axis within the strategy the technological component, both for the recruitment and follow-up. And at this point, I would like to bring Caroline Bucky, who says, in a world where the technology moguls are becoming large investors in research, which should not be carried out by the seductive idea that young college graduates use the new technologies may on their own solve public health issues from their computers. And that's something that I believe is one of the most fundamental learnings that we've had in the Promesa project. Because we believe that even if we believe that by creating an app or a monitoring instrument, everyone will know how to use it and how to perform it. And even now with the COVID pandemic, many people have learned to attend to teleconsultations, and there is a lack of versatility or trust in how to manage all of these strategies, because this requires training, and training not only for the patients but for the healthcare personnel. And there are some components that the systems still cannot overcome. For instance, human relationship, understanding, and feelings. So we propose the construction of recruitment, and one of the fundamental axes in this is communication linked to these technological components. So it was fundamental, as in one of the prior presentations, all of this multidiscipline management that may occur in all the stakeholders of the project. There was a moment where patients were detected, another time to evaluate the patient psychologically, following the patterns for research regulation in Colombia, and to decide whether the patients were included or not, depending on the particular features or characteristics. And at that time, we also assessed the access to technologies the patients have in their places of origin. That is to say, even though in Colombia, cell phones in Colombia cover about 80% of the population, but not all of them have data plans. So that's fundamental for the carers to upload the data and for us to have the relevant measurements. So with all of these conditions, we were assessing in advance in order to avoid inconveniences in the development of the project. And as assessment activities were carried out on the patient. So we have the heads of the department that needed to have an integration between how we would do things, and we developed an assertive communication protocol, because on many occasions we don't have a clarity on the conditions or on the information, and we have fallbacks. So communication is important to have these clear guidelines for them, and to have a clear flow of communication for the patients at a given time. So with this recruiting aspect, and which is something to highlight in the Promesa project, is the recruitment of carers. Both the carers and the healthcare practitioners learn, or will learn, by means of a specifically tailored curriculum. And so we learned what the patients are like, what are the families like, what are the dynamics, their conditions, the strengths and weaknesses, and so on. So this gathering of knowledge allowed us to create the foundations for optimal follow-up of the children. Here we can see the coordinator of the study with um, the chief nurse working with the parents on the different stages of the project. Oh, sorry. Within that learning, we ensure those conditions that decrease the risk of adverse events in technological interventions. And it has been described that there may be adverse events because of miscommunicated information, or they simply leave the project because they don't find a continuity. So one of the recommendations done internationally, we see there must be an instruction about the proper information for the users. So one of our indicators is precisely platform glitches and those conditions of difficulties found in the patients, and also trying to find an accreditation and an assessment of the quality components in this project in order to decrease the risks and the fitness of the instrument. So for us, seeing a screen like this is mostly intuitive, but we have a non-negligible amount of population that were used to manage this because they didn't know smartphones. They also need to train about the time for recharge the phone, looking after cleaning of the phone, how to manage the connection. So that requires time and patience to provide this proper training to the patients. So these learning components were also given in a booklet which acted as a training manual where they could go over and review. This booklet has components to know the disease of the child, and there were some gaps, some blanks, sorry, that the parents filled with regards to the disease of the child. Also, concepts of alarm, activities to care for the child, warning signs, medication management, the use of technologies and platforms, and the controls and follow-up. So this is the screen the head nurse, Carol Castillo, has, where they register all the information being generated. All of that information is generated automatically. All other information is to be taken directly from the history. There are pre-selection components, psychology assessment, instruments applied in psychology, surgical times, access barriers, video calls, follow-up, ambulatory medical controls, and so on. So absolutely all of the activities have their corresponding records, and from these records, some goals were derived in particular. So the monitoring of alarms were done, and if they didn't have the adequate patterns or readings, they would generate an alert to communicate with the parents. The contact with external healthcare personnel is important because we, besides generating this booklet for the patients, we generate another for medical personnel, and this allows to have contact with the Promesa staff. That was the strategy, for instance, we were able to implement to have many children vaccinated because children would come to get vaccinated and they were denied of it because of the fear of a reaction. And once they call our center to verify that they could be vaccinated, we established that communication with those other professionals. So that link, even for a rural physician, contacted the system to evaluate the conditions of a child. So In the instructions, we have an instruction manual for medical conditions and others. So with regards to monitoring, it is important to know that we have the idea in principle to make it more than collecting data during follow-up. The components of follow-up are not only comprised by the doctor and the nurse coordinators, but also the social network support or the family support. It is worth to clarify that in this project we were aware of the economic limitations of many patients, and that's why uh, a cell phone was given to them as a lease with a data plan. The management we gave is that this is not a mobile phone, but a follow-up device for their children. They also were given a pulse oximeter, the feeding tube, and the portable scale, and all of these pieces of equipment were returned when they came to the second stage. The pulse oximeter device was also connected to the mobile phone, so the information could be transmitted automatically. Besides, on the booklets, they were able to record the data manually. Here, the caregiver has an active role as a collector and supervisor of data, so they can take these records and they are able to know what these numbers mean for the child. So this flow diagram continues trying to seeking to get the monitoring at home, the feedback in a daily basis, and the safe arrival to a second stage. During the pandemic, we continue working. We were prepared for the pandemic because we have been working virtually without difficulties. This is one of the samples of one of the patients' homes where distance they can send information from the distance. That's the nearer town from that house. And oftentimes there were doubts on how to administer the medications if the patient has a fever. So we use photos and meditations to solve those questions directly. That's why we have those tools. So in the literature, one of the recommendations is to avoid the feeling of abandonment by the patient. That's why we have this follow-up to know when we would get the contact so these patients will not feel abandoned. These patients have something what authors call an emotional roller coaster. Sometimes they feel well, sometimes they have feelings near depression. So this accompaniment should be maintained over time. That's why Dr. Paula Perez mentioned or continues this follow-up from psychology when necessary. Obviously, they will be exposed to other conditions. 50% of the patients and carers have reported that they lost their job, they decreased their acquisitive power, they require a high degree of organization responsibility. So with adverse events, we also have recommendations for safety of the patients, not to neglect the children, to avoid them falling from the scale, for instance. Another component in the loss of patients is the loss of trust. Therefore, the contact was permanent and also the availability was also given. We also created WhatsApp groups for the carers so they could share different topics. And there was a feedback, trust the feedback, and in this way they helped each other. They help among them, the carers, get mutual support. For instance, to get a special baby formula. So social support was very important, as well as sensitization about the management of the team. Um, One of the doubts in the administrative group was about the return of the equipment. Um, we only had one case where one of the patients got stolen her mobile phone, and it was reported, and there was a reposition for that. That was not inconvenient. We have an insurance on that pieces of equipment to avoid inconveniences. That was the only difficulty we have. All of the pieces of equipment have been returned without any inconveniences, nonetheless. So not everything has been perfect. There have been patients that haven't been able to complete the patient. For instance, in the case of Ivana or Miguel Angel, in the case of Ivana, had an aneurysm that complicated the second surgery. So there is still room for improvement. There are things to do at the level of the healthcare personnel, because even though we have a good monitoring, there are particular limitations. We have achieved an identity of the project. It is pleasant to see how the specialists, when they come and they say, "Hi, you're in Promesa, so how much should your baby weigh? How is their pulse oximetry?" So we notice there is the knowledge and involvement of the patients, and our true reward is to see the babies on the second surgery and when we see them growing up. Thank you very much. Bien, buenos días. ¿Me pueden escuchar? Sí. Y pueden ver mis diapositivas, ¿correcto? Sí, 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 las podemos ver. Ok, muchas gracias. De nuevo, buenos días a todos y muchas gracias a Javier y a los organizadores por invitarme a compartir la experiencia del Hospital de Niños de Filadelfia en cuanto al monitoreo en casa. No tengo conflictos de interés con respecto a este tema. Y estos son los temas que espero cubrir en los siguientes 15 minutos. Bueno, como todos sabemos, el mejoramiento del manejo quirúrgico y postoperativo ha llevado a mejor tasa de sobrevida después de la paliación neonatal, incluyendo la operación de Norwood. Sin embargo, el periodo de interestadio entre el alta y el estadio 2 es un periodo vulnerable. Como vimos ayer en la presentación, el periodo interestadio es un periodo de alto riesgo de mortalidad que presenta readmisiones en el que la alimentación, la nutrición y el crecimiento presentan problemas. De nuevo, aquí vemos el dibujo de la operación de Norwood con el shunt de Blaylock Taussig y el shunt de ventrículo derecho a arteria pulmonar del doctor Sano. Como vimos ayer, la carga hemodinámica se debe a una circulación ineficiente del ventrículo único que suministra tanto el flujo sanguíneo pulmonar y sistémico y está sobrecargado antes del procedimiento de estadio 2 o la conexión de arteria pulmonar. La disfunción ventricular, la regurgitación de válvula atrioventricular, como mostró el doctor Silverman, y las lesiones residuales pueden ser factores influyentes. En este periodo vulnerable, desafortunadamente, vamos a ver los bebés van a estar predispuestos debido a estas características, a estas enfermedades, tienen una reserva cardíaca mínima para cubrir esas demandas metabólicas incrementadas creadas por la falta de esta circulación intercorriente. Antes de la implementación del monitoreo en casa, en el hospital, teníamos una gran tasa de mortalidad interestadio. Por ejemplo, en los 80 y los 90 esta tasa interestadio se acercaba al 14%, y no hubo mucho cambio hacia finales de los 90 y la primera parte del nuevo milenio. Y de manera similar, en la reconstrucción de ventrículo único, en ese estudio, vemos con casi 550 infantes fueron tomados de manera aleatoria en diferentes centros en Norteamérica, las mortalidades interestadios se acercaban al 15%. Brevemente, esta es la experiencia del hospital antes de la implementación del programa de monitoreo en casa. Esto empezó en enero del 98. La mortalidad interestadio fue de 10.5%, perdón. Se identificó como el septo auricular intacto como un factor significativo de riesgo. Otros factores incluyeron arritmias postoperatorias y una mayor incidencia de complicaciones respiratorias. Entonces, el concepto de monitoreo en casa y vigilancia fue presentado por el grupo de Wisconsin. Este fue un estudio que fue publicado en el 2003 y el concepto era muy simple. Se les daba una balanza y un oxímetro y se les pedía que llenaran una bitácora diaria y también registraran la alimentación, y se tuvo un enfoque en la comunicación entre los padres, y los médicos, y eso se trataba de reducir la mortalidad casi a cero. Este concepto se utilizó nacionalmente en el 2008 con el establecimiento de la colaboración de mejora de calidad o de NPC-QIC, con la meta de disminuir la mortalidad de infantes en síndrome de corazón izquierdo neoplásico, y la mayoría de centros en Norteamérica ahora son parte de este grupo colaborativo. Las ventajas del monitoreo en casa incluyen la educación continua y el involucramiento de la familia, la detección temprana de problemas potenciales con el uso de estos equipos, una comunicación continua entre la familia y los prestadores de salud. Yo creo que esta es algo que es clave. Es muy importante que las familias accedan a este programa de monitoreo, y es que se tenga una buena coordinación de cuidado entre los prestadores de salud. Y otra cosa que se ha estandarizado, se ha establecido la estandarización de prácticas de cuidado con las mejores prácticas que hemos identificado, y ha ayudado a reducir la variación dentro del cuidado entre instituciones. Se ha establecido entonces este programa de monitoreo en el 2010. Este no es solamente un programa de monitoreo interestadio, se trata de un programa de monitoreo de ventrículo único, y queremos concentrar todos los aspectos de cuidado, incluyendo el cuidado antes del alta. Entonces hay dos componentes amplios: es el planeamiento del alta, que incluye la educación de los padres, la coordinación del cuidado y la establección del tiempo del alta, y el monitoreo en casa a través del monitoreo diario, y los detalles que se van a discutir en las siguientes diapositivas. Básicamente nos aseguramos que hay una estandarización de los criterios para dar de alta de neonatos. También hemos estandarizado la educación parental antes del alta para tenemos un salón de educación en el piso cardíaco en el que todos los padres pueden recibir una educación bastante estandarizada antes del alta, y es importante obtener o saber cuáles son estas alertas, señales de alertas en los bebés. También los padres se les espera que realicen monitoreo con oximetría y que registren la alimentación diariamente. También tenemos un programa en el que tienen visitas semanales de enfermería en la que se va a documentar la saturación de oxígeno y que estén en contacto, el modo de alimentación, el tipo y la preparación de la fórmula. Tenemos este personal que está dedicado con el profesional que está en contacto con las familias a través de llamadas semanales. También tenemos un dietista registrado que hace estas evaluaciones antes del alta y provee asesoría durante el periodo interestadio. Tenemos una conexión con pediatras. También se recomiendan visitas alternas entre pediatras y cardiólogos para que el bebé sea visto de manera semanal, y para los pacientes de shunting son revisados mensualmente por el cardiólogo. Tenemos un equipo dedicado que revisa a los pacientes de manera semanal y uno de los cardiólogos de guardia para los pacientes dependientes de shunt. Y como parte de la estandarización del cuidado para el estadio 2, usualmente se programa a los 4 o 5 meses de edad, excepto en el caso de vena cava bilateral. Algo que quiero resaltar es que aunque tenemos un equipo médico ISBMP dedicado que incluye 7 cardiólogos, no tenemos una clínica dedicada a ventrículo único. Tenemos comunicación continua en cuanto al manejo coordinado a través del periodo interestadio entre el equipo del ISBMP. Existe una muy buena comunicación entre esos cardiólogos y nuestro equipo, especialmente entre los profesionales de cuidado avanzado. El objetivo de nuestro programa es el de optimizar el cuidado y disminuir la mortalidad interestadio. Iniciamos con todos los pacientes de ventrículo único y lo hemos extendido a todos los pacientes dependientes de shunting, incluyendo los pacientes de shunt PB, que es en promedio un volumen anual de 50-60%, aproximadamente 30 de corazón izquierdo hipoplásico y otros 20 dependientes de shunt. Ya hemos discutido un poco sobre la filosofía. De nuevo, la clave aquí es el de tener un médico dedicado, la comunicación constante con la familia, la revisión de los datos, que actualice el estado de los pacientes y es dependiente de los cambios continuos y al manejo. Ahora, nuestro estudio tuvo un impacto comparado con la cohorte del ISBMP de diciembre de 2010 a 2016, con la cohorte histórica de enero de 2007 a 2010. Entonces publicamos estos estudios. Monique Garner es una de nuestras incentivistas cardíacas que publicó los resultados en YAHA en el 2019, hace más de un año y medio, y en los controles históricos incluyeron 160 individuos, incluyendo 131 sometidos a Norwood, comparado con 166 sujetos con 116 sometidos a Norwood. La línea base o las características básicas comparadas en el grupo ICBMP era ligeramente más maduro desde el punto de vista de edad gestacional. La prematuridad era bastante común, el diagnóstico prenatal, 97% en el grupo de ICBMP. En cuanto a las patologías, la mitad de los pacientes presentaron síndrome de corazón izquierdo hipoplásico y las otras categorías diagnósticas se incluyeron en esta tabla. Otras características entonces al momento de la operación de Norwood en el grupo histórico era un mayor porcentaje de shunt BT comparado con el shunt de RBFA. El tiempo de bypass cardiopulmonar fue un poco más corto en el grupo de ISBMP comparado con el grupo histórico, y todos los características postoperatorias fueron bastante similares, incluyendo la duración de la estadía en el hospital de 22 días en el grupo ICBMP y contra 24 del grupo histórico. Las características al alta no hubo mucha diferencia entre los dos grupos, pero queríamos también ver si había una diferencia en la frecuencia de prescripción de digoxina, que no hubo mucha diferencia, y la función ventricular también se presentó bastante similar. Y aquí vemos los resultados. Si vemos en esta curva los grupos de ISBMP que se muestran en rojo, una disminución en la mortalidad, es decir, la tasa, la incidencia de muerte fue mucho más baja comparado en ISBMP, comparada con el grupo histórico, con una mortalidad general de 5.4%, comparado con 13% en el grupo histórico. De nuevo, aquí vemos la mortalidad interestadía de la población HS, que fue de 4.8%, y lo que es interesante es que no hay diferencia entre la mortalidad interestadía de los pacientes que solamente tuvieron shunt. En cuanto a la edad, en operaciones estadio 2, la edad era menor, pero el peso del puntaje del Z-score fue mucho mayor, de nuevo mostrando que nuestro manejo nutricional estaba funcionando. En cuanto a las admisiones en interestadio, fueron más comunes con 63% en el ISBMP comparado con 46% en el histórico. No hubo diferencia en la frecuencia de cateterización no planeada interestadio. Ahora, viendo los resultados del estadio 2, no tuvo un impacto negativo, como se explicó antes en el grupo ISBM, aunque hubo mayor incidencia de cirugía cardíaca concurrente y cateterización durante la hospitalización de estadio 2. No hubo diferencia en la mortalidad entre los dos grupos y la duración de estadía fue muy similar, con una media de 7 días. Entonces, la mejoría en general de la mortalidad de interestadio hizo que nuestros bebés fueran más robustos y no cambió los resultados del estadio 2. En general, entonces, fue bastante bueno, similar a lo que han mostrado otros centros. Entonces, a nivel nacional, este es un estudio publicado en el 2017 y el equipo colaborativo pudo reducir la mortalidad de interestadio de 9.5 a 5%, que fue muy similar a lo que hemos logrado con una reducción relativa de 46%. Ahora, este grupo colaborativo tienen un gran esfuerzo trabajando juntos, tiene un gran impacto en nuestros pacientes. Ahora, ¿qué es protector? Este es un estudio retrospectivo que fue publicado en 12.3% que no se les administró digoxina, comparado con 2.9% de aquellos que se les administró digoxina. Y este gráfico muestra esa relación, y estos resultados fueron replicados en una cohorte más grande utilizando los datos de NPC, QIC, mostrando de nuevo que la digoxina en el periodo de interestadio puede ser protectora. ¿Quién iba a pensar hace unos 20 años que la digoxina iba a ser responsable de esa mortalidad interestadio? Ahora, ¿qué ocurre con el estrés de los padres? Recuerden que ayer hablábamos sobre cómo el estrés aparece durante el periodo interestadio y el crear esta red de apoyo para los padres y las familias que pueden estar involucrados en grupos de apoyo y son parte de nuestras organizaciones, y esto potencialmente puede aliviar el estrés. Pero hay datos que tienen algún impacto para reducir el estrés. Una de las cosas que hicimos en el hospital es queríamos revisar el efecto de un programa de monitoreo en casa de telemedicina por 4 meses. Es el programa REACH, que se utilizó en el cuidado usual del estrés parental. Se aplicó 4 meses después de la alta hospitalaria o hasta readmisión en el estadio 2. Además del cuidado usual, se asignaron días de padres infantes a la intervención de Rich y recibieron diariamente un mensaje de texto o una llamada de teléfono que era revisada por la APM y se tuvo videoconferencia o telemedicina 2 veces a la semana con una APN. Revisamos el índice de estrés parental, una escala de estrés postraumático y pudimos involucrar a 219 diadas de padres infantes. No hubo diferencia entre los dos grupos. Yo quiero señalar que tanto estrés sentían estos padres. En el puntaje PSI, el 99% comparado con los normales, casi 20%, perdón, llenaban los criterios de estrés postraumático y el score ULQ en estas familias muestran que tenían una calidad de vida relativamente baja. Cuando se adicionaban al cuidado usual, la intervención de Rich no se asoció a una mejoría en los resultados de los padres, es lo que buscábamos en esta área. Entonces podemos ver que los programas de monitoreo en casa existen en la mayoría de las instituciones, reformando la paliación para pacientes con enfermedad de ventrículo único. Es una estrategia efectiva que puede ayudar a disminuir la mortalidad interestadio y permite una mejor comunicación con las familias y la identificación temprana de signos fisiológicos de deterioro. Esta mortalidad mejorada, hay una mejora en la mortalidad, pero también hay mucho trabajo por hacer para lograr que los pacientes vivan más, para que logren tener una vida escolar y académica. Obviamente los resultados neurológicos de los niños van a tener influencia y se ha vuelto mucho más obvio que los pacientes adultos van a poder observarse problemas mentales. Esto hay que llevarlo entonces mucho más allá del periodo interestadio. Los resultados han mejorado, pero estas diadas infantes padres siguen siendo frágiles al momento del alta. El monitoreo en casa ofrece apoyo a los padres al momento, pero siguen bastante estresados. El rol de la evaluación psicológica durante este apoyo continuo durante la hospitalización es importante. Y también hay definitivamente un rol para la telemedicina, lo que ha surgido dramáticamente ahora con la situación de la pandemia. En el momento estamos utilizando mucho más la telemedicina de lo que lo hacíamos anteriormente. Yo quiero agradecer a todo mi equipo de ISBMP, especialmente al doctor Ron, a Alison Stack, al doctor Ron, doctor Giglia. Este programa no podría continuar sin nuestra profesional Alison Stack, quien es el alma y el corazón de nuestro programa. Es un profesional dedicado. Eso señala el rol de un profesional dedicado en el éxito de estos programas. De nuevo, como una conclusión. Muchas gracias por su atención y su amable invitación. Now continue with the presentation. We have Dr. Alejandro Lopez, a physician from Universidad Militar, graduated in 1986 in Mexico, completed the pediatric residency in the Central Hospital in Mexico, professor of pediatric cardiosurgery in Boston Hospital. Then he came back to Mexico. He was in the pediatric ICU in the Central Military Hospital as director of the ICU and as medical director as pediatric cardiologist in the National Pediatrics Institute in Mexico. Afterwards, he was in Pittsburgh. That's where we met him, and he supported all the telemedicine program at the international level. and he acquired experience. He gave the support from Pittsburgh to our ICU, to our group, and he's currently working in the cardiac intensive care unit as medical telemedicine director in the Children's National Hospital in Washington. Welcome, Alejandro. It was a pleasure for me to introduce you. Claudia, thank you very much for this um, random opportunity for sharing with you and your audience our experience in the development of our telemedicine program. I want to thank for this opportunity the organizing committee, Dr. Javier Castro, you, and the Cardiovascular Foundation, undoubtedly a leading institution in Latin America in the promotion and improvement of, of patient care, uh, cardiology for pediatric patients. Let me share my screen, just a moment. See? Yes, we are seeing your presentation, doctor. Yes, we can hear you as well. So we're going to talk about our telemedicine program in Children's National Hospital in Washington, D.C. Of course, we need to approach the implication that this COVID pandemic has had on our program, sorry, and for all telemedicine programs in the region, where they want to implement a response to this crisis. So the first thing I would like to know to say is that Children's National has implemented a successful telemedicine response to the COVID-19 pandemic. I can say this first of all because I believe we were able to protect children and the families and our healthcare team. We were able to use virtualization of care by means of massive training and a group of telemedicine interventions to outpatients and also to patients in the hospital. We were also able to cooperate in the mitigation of the financial impact that any institution would have on this pandemic. Let me try to show you my point. So looking back in history, this began years before the pandemic. And looking backwards, we were preparing for the unknown. The history of telemedicine at CNH is long. We've had more than 20 years of experience. Our institution has been the leading telemedicine provider, more focused on pediatric cardiosurgery, um, by reading remotely echocardiographic studies. We have international liaisons all around the world. And this is the framework in which some years ago, Ricardo and myself joined the institution. So the first thing we did was to have the vision to achieve a pediatric virtual hospital where the clinical expertise would be coupled to technology in order to maintain children and their families as close to home as possible. Also, advance healthcare interventions at the time needed, regardless of where they are located, and also to transform the healthcare model from from reactive to preventive attention. Also, looking back, we need to organize the team to better respond to the contingencies that life gives us. This is the team we have devoted to organizing the last few years. So we have outpatients divided into primary care, ambulatory specialties, telemedicine to schools, approaching care. We avoid families to lose uh, days of working days taking the children to the doctor. We take the care to the schools in telemedicine and also in the prevention of epidemic outbreaks also. So virtual attention in the ER, to have the virtual triage, for instance. An inpatient, we have hospitalized patients with medical specialties, or for instance, in cardiology with remote hospitals, and also in our own hospital, as you will see, we have the CICU, and the NICU, and the PICUs, also ensuring the dedication specifically to obtain, and also grants in order to obtain funding to sustain this program. So it was necessary to have a complete update and upgrade of our technological capabilities, without which it's not possible to have telemedicine, a massive telemedicine or telehealth operations. We dedicated intensively after diagnosis. We found issues or problems that were improved after this diagnosis. We also would need to go to the institution and sell this idea. So we need to organize a strategic business plan, leadership from the hospital. Once leadership from the hospital incorporated in its own strategy that happened in 2018, and then the update or the upgrade, as I mentioned before, for the ICT infrastructure. And last year, we began formal operations from our command center, and we devoted to change the telemedicine strategy or the platform, our virtual tool for the consultations. So the road towards something we didn't know that was coming. These are the monthly consultations we had with outpatients. So and towards the end of 2019 or the mid 2019, we had a transition to the Zoom platform. We didn't know back then that everyone would be using Zoom now because of the pandemics. So at the beginning of this year, with the emergence of COVID, after a few legal changes in the US, which allowed the uh, to provide telemedicine consults in other states different from where we are, that allowed us to have telemedicine program response plans, which was ready by late March this year. So we began with a deployment plan for performing telemedicine, and so including virtual triage in the emergency room. I'm sorry, the sound is breaking. So in critical part, Nike, Nike and PIQ. Sorry. So fortunately, as you saw, we had been preparing in a very energetic manner in order to have a procedure that was possible to replicate or multiply. We didn't know how useful that would be over time. This shows the number of telemedicine providers. In January and February this year, we can see there was a very small growth, So once we began executing our plan, the multiplication of healthcare workers, physicians, providing telemedicine multiplied dramatically in March. So from 82 in February to 920 in March and 3100, 1300 in late August. So you can see here the exponential growth of telemedicine visits due to COVID-19 from 77 to 2700 per month and then to 16,000 in the peak of the pandemic. And then there is a small decrease, a relative decrease, modest, but still maintaining a robust level of telemedicine visits. So we are providing currently about 8,500 a month. We have more. We are having now more face-to-face visits, but we are coming back to that situation where we will have more telemedicine. In the situation of hospitalized patients, at least most of you know, there are major problems in all the ICUs. One of the major problems is the persistent presence of potentially hazardous adverse events such as cardiorespiratory arrest, the need for emergent tracheal intubation, the ECMO cannulation as well, or emergent. Human error is also involved in a large percentage of these problems. So how do we increase our own intelligence and efficiency to try to eliminate these problems? That's a fundamental issue. So the model we've tried to set up or to establish, and, and that's an evolution of what you know and other members of the foundation. It's a more intensive management looking for a continuous surveillance following the model of other industries um, compared to us. For instance, commercial aviation. In our command center is a place where we believe the clinical expertise, the virtual technologies, and artificial intelligence meet to contribute a second safety layer on the care of the patients. The era of lonely decisions or lonely errors that we've had as practitioners that needs to go to disappear in history. So it is better to be accompanied. So I believe during the 30s or the 40s, some expert pilots perhaps would complain about something strange called the control tower. I don't believe anyone flying today or a Boeing or an Airbus would complain about the control tower. So this is something we would go eventually to. So our workflow begins with a systematic review. So we begin with the monitors, the video, remote video cameras, the use of artificial intelligence, which are like virtual bloodhounds, trained, uh, virtual hound dogs trained to find different trends, for instance, oxygen delivery or the risk of heart rest, the electronic records, the imaging studies, and ultimately to receive a communication with the clinical team directly involved with the patient. So this care model can be uh, can be replicated with the use of artificial intelligence in any context, maybe with patients in our own hospital or in the regional or international contexts. This is one example of a baby, a 3-week-old baby, post-operated with HLHS with Norwood procedure who has been extubated. You can see in the tool here, this is called the T3. You can see how it into extubation, which is around here or here specifically. You can start seeing an increase of the heart rate and a decrease of near to red spectroscopy decrease. You can see an increase in the respiratory frequency. So when we start monitoring after extubation, we see how we see the index. We have a patient assessment with telepresence with the robot, and then in step 3, we agree with the fellow that the patient needed to be reintubated. One of our own specialists was in charge of that intervention there. The cardiac intensivist was on the other side of the unit. So we went over there with the robot. We communicated, okay, we are agree the patient needs to be intubated again. The patient was assisted and avoided cardiac arrest. So in summary, our activities in the last almost 2 years, we have performed about 6,000, almost 6,000 surveillance, virtual surveillance activity or remote surveillance, of which 2/3 the result was non-critical communications. So 29% of were non-critical communications. Findings we found that, but are not imminent. And then 144 times or 3% we've had emerging critical communications with the cardiac intensive specialist or lab or class or lab test findings or imaging finding which may cause of danger and sorry. So these are the reasons why we have critical communications to the clinical team. We have most of them were dangerous trends, medication adjustments, fluid balance issues, infections, kidney failure disease, arrhythmia, imaging findings, nutrition issues, and so on. For the response to the pandemic, by improving the social distancing and giving more safety to our patients and our own personnel, we have the virtual rounds whereby using our telemedicine robot and a telemedicine camera, we have a pharmacologist and some specialists or fellows attending in a remote manner. And with this, we decrease the need for having the team present in the same place, and thus we improve the social distancing. We also implemented teleconsultation for specialties, for the COVID units, for these units, particularly devoted to COVID, and for other places different from the intensive care units. For instance, the ER. We have virtualized also the X-ray rounds, or those early morning rounds where we may have difficulty finding 40 or 50 people in a conference room face to face to review X-rays or very general things. So we have made them virtually, completely, also improving social distancing. One thing you may be familiar with, we have we have implemented under the leadership of Ricardo. Speaking about tele-education, we've had already 20 weekly multi-center international meetings with 72 institutions from all continents, where we shared early experience from the epicenters and also about the experiences with regards to organization, the challenges and issues. I believe this has helped us a lot to begin, and also for the others who have participated to understand what was going on and also plan a better response on for the future. And then to get funds and to sustain the effort, that's important. We have been dedicated to that. We have here the planning for our next command center. As you can see, we are going to do this next year. Hopefully, the pandemic will be under control by then. Otherwise, these are the plans we will. This is the place where we will provide the response. This is not possible without a great team. So this is our telemedicine team. So in summary, as I said at the beginning, I believe we have implemented so far a successful telemedicine response. However, the virtualization of care is here to stay. However, there are significant challenges remain. For instance, the human factor, our desire for a direct connection, to see each other, to see our body language, to touch, uh, see around ourselves. So this feeling of community is a great challenge. But I believe by using video images humanizes a bit these virtual consultations. But also we need to keep using uh, techniques to send an empathic message so the message is received properly. Financial issues are ongoing, issues with laws and regulations. Perhaps we want to go back to the previous. And also technology. Technology will also go ahead. Last, as General Eisenhower said, after his experience in the American Army in World War II and in government as a president, he said, in preparing for battle, I have always found that plans are useless. They are not used as originally designed. However, planning is indispensable. So we need to be ready for the opportunities when they occur or when the challenges occur. We don't know what a challenge would appear. And we don't know what are we preparing for, but we need to be prepared. Thank you very much. Alejandro, thank you very much for your presentation. It has been an excellent topic. Thank you very much for sharing the experience of the program that you have worked on for so many years and has allowed the survival of many patients and the support to many institutions around the world. Thank you very much. My pleasure, Constanza. It's a great, again, I'm very pleased to greet you again. Well, continue with our program. We have talked during all the morning about the importance of breastfeeding in weight gain in these children with complex congenital heart diseases. That's our following presentation in breastfeeding, how to have a successful breastfeeding. I want to introduce Dr. Maria Vargas Umaña. Dr. Vargas Umaña is a physician from Universidad del Rosario, pediatrician from Universidad del Bosque, candidate for master's degree in Universidad de los Andes, and instructor, certified instructor in breastfeeding. Dr. Umaña, Vargas Umaña works in Congénitas Center and in Harker Pediatrician Center as consultant in breastfeeding. Thank you very much, Dr. Vargas, for joining us. Thank you, Ana Maria. Good morning. I want to share my screen now. Oh, yes, here we go. Yes, perfect. That's ready. So today I want to talk about one topic that really I feel passionate about, which is breastfeeding and the importance of breastfeeding in children with cardiopathies, how to make families to integrate around breastfeeding. with all the aspects that have been mentioned before in the morning. So I want to refer to recommendations as such in the literature for patients with cardiopathies. The recommendations are based on the experience with premature and neonates, and I was I based on the literature to design the 10 steps to promote and protect maternal breastfeeding applied to patients with heart diseases. So breastfeeding is important for the prevention of complications in patients with congenital heart diseases. We also need to talk about how to initiate and maintain uh, breast milk, also the preservation and management of milk, the care and oral care with colostrum and feeding, breastfeeding. Sorry. So children born with heart issues are in larger risk of complications, and breastfeeding is seen as a medical intervention for these pathologies, both for the treatment and for the prevention. The pathologies more associated are necrosis, enterocolitis, cheilothorax. With regards to enterocolitis, patients with CHD with single ventricle have more risk to develop necrotis and enterocolitis, and breastfeeding has a crucial role with regards to the reduction of incidence and the severity of this condition. And the benefits are not attributed not only to the components, but the breastfeeding. Milk promotes the growth of a healthy microbiota. Sorry. Breastfeeding also promotes gastric motility, maturation of the digestive tract, decreases the permeability of the intestine, the bowel membrane, decreases the activation of toll-like type 4 receptors. It has anti-inflammatory effects on the, um, and it may reduce, I'm sorry. The guidelines recommend breastfeeding from the mother and donated breastfeeding. In Bucaramanga, we don't have this sort of banks, but fortunately in the country, we have these sort of banks that operate very well. It's a very established network nation. Hopefully in Bucaramanga, we may have this facility. Pelothorax is a rare complication associated to the trilogy of a lot. It leads to a deficit of protein on the patient and is managed by means of formula with medium chain triglycerides accompanied to weight gain. It needs to be enriched with triglyceride oils. Sorry. So difficulties in feeding, we see them a lot, in particularly in patients with cyanosing cardiopathies. There are patients with increase in the metabolic demand, patients that have nausea and more difficulties in having a prolonged suction. Besides, the procedures in patients with cardiopathies, such as the post-operative of Norwood, may have a poor oral and coordination, may lead to aspiration. Ventilatory support is also associated to alteration in the suction, and the duration of the cardiopulmonary bypass can also have alterations on feeding. So when we have these situations, um, breastfeeding is important because patients that receive maternal milk have a larger increase in weight, uh, and unlike many specialists fear, it is important that we know that the relationship and the score is important. Breastfeeding is better than formula because Breast milk is easier to digest. It helps the digestive tract. It has a better concentration of protein. It favors the growth of microbiota for calcium and iron absorption. It has immune factors that prevent complications in hospitalized patients in case of infections. So these are patients that re-enter less. And besides, it have enzymes which are very digestive and decrease the probability of gastrointestinal complications. So we may conclude that breastfeeding is a significant medical intervention in patients with cardiopathy. This is a patient in a kangaroo program. In the kangaroo plan, breastfeeding is very important. It has been seen that patients has less desaturation of oxygen, less fall of body temperature. Breastfeeding is safe and it favors the creation of a mother and son bind. This is very important for the care to make the mother participate in in the responsibility of the care and also to provide the strategies to allow the mother to feel safe. Ultimately, she will be with the baby at home and the family, and breastfeeding generates this link, this bonding. So it's important to begin training for the mother. So it is false, adult, that direct uh, breast feeding is more difficult. That is false. Unless the baby has a disorder in the coordination of the suction, we do it directly. It's easier, as we mentioned before. So the support to the families, we begin with a prenatal diagnosis. We ensure consulting in prenatal breastfeeding and how to support the mother to have a successful breastfeeding. These are the recommendations, or we should mention in the pediatric consultation, in cardiology, or any consultation in the benefits of breast milk. Let's say that children grow better, so we need to highlight these guidelines in from the World Health Organization. These children grow better. They decrease the probability of infections and the possibility of sudden death syndrome. In fact, the recommendations of the American Academy of Pediatrics, the best evidence against sudden death is breast milk. So with this, we're gaining a lot. They favors bonding, and in the long term, the possibility of having a more better IQ. It reduces the risk for the mother for breast and uterus cancer, and it decreases the likelihood of obesity, diabetes, and hypertension in the adulthood. Um, and so after the birth, if the lactating baby is hemodynamically stable, the skin to skin contact will be favored. So that's the golden hour for breastfeeding. Once the baby is born, leaves the placenta, the progesterone levels drop. So we won't have a peak of prostaglandin after the birth. So when prolactin is joined to, oh, sorry. So I would take advantage of this first hour of life suction on the breast. The possibility of this mother to lactate will be significantly greater than when we don't have the timely intervention. So we weigh the baby, we apply vitamin K, even if they are important elements in the care of a newborn. What is vital at the beginning is that if the patient is stable, with a good tone, that cries in good color, we know that patient can have a skin to skin contact within the first hour, and then we can do the other intervention. So it is important during this first hour to favor the bond between the mother and the child. It strengthens that bond, weight gain, preservation of oxygen, and less consumption of oxygen. Some patients with cardiopathies, this is important. In patients with cardiopathies, it favors colonizing of maternal joints, decreases the stress levels in the newly born. It facilitates thermal regulation, decreases energy consumption, decreasing the risk of hypoglycemia. The link, again, the bonding and the crying time favors the correct grip on the breast and increases the frequency of feeding. If we cannot have a direct feeding from the breast, it is important to have the skin to skin contact. We need to advise the mother on the early initiation of obtaining the colostrum within the first hour. And as I mentioned before, if if direct feeding cannot be done, we can replace it by manual extraction or with a pump. So breastfeeding, if done by extraction, we need to it needs to be done every 2 or 3 hours during 24 hours a day, emphasizing to to do it at night because prolactin increases and we need to take advantage of that. If there are difficulties in initial feeding, extract colostrum and have aided breastfeeding until the baby is prepared for direct suction. If there is no choice because of lactogenesis for premature patients with cardiopathies and cardiopathologies, I'm How we preserve this milk, it's based on the Ministry of Health guidelines. Maternal milk can be preserved at ambient temperature for 4 hours. Well, these standards are different from the European standards. Um, Sort of these social variations allow a lower mean duration of life. So milk is always preserved in the internal part of the fridge to avoid being close with strong odor foods. It can be preserved at room temperature for 4 hours in the fridge, for 12 hours in the freezer, up to 15 days. It is you can throw it in a bain marie directly, and then it makes the milk to be warm. So the following 5 steps would be non-nutritive for breastfeeding, the direct suction on the breast with, when we have a low weight of birth for a premature baby. So here the family is important. The mother needs to be seated comfortably, maybe in a resting position, seated or laying in the bed. So here the mother has the baby below the chair, and takes the baby from the neck, and here the baby is suckling. And during the night, they can use this sort of breastfeeding to avoid fatigue on the mother, or the previous position is also observed, the cubitus position. I'm sorry. So I'm so lost. I'm sorry. I'm losing some parts. I'm sorry. So patients with cardiopaties, it is important to recognize that breastfeeding influences on weight gain. Sometimes we see the opposite. We see that patients cannot gain weight because we predispose them to diabetes and overweight in the future. So with all of this, we have considered. I invite you to promote as healthcare professionals and as parents to protect, to promote breastfeeding, to know that the important within the first hour of life is important, and it's also important to have the accompaniment for a professional during the process of breastfeeding. Yeah. Sorry for the interruption during the translation. We had a technical issue with the microphone. Thank you very much, Maria, for your presentation. It is important to remember that breast milk is important for kids because they gain more weight and they will get in better conditions to second surgery. Therefore, it is important and fundamental to, to see this. Well, we are about to enter into the last session of the morning with Dr. Norma Barajas. Norma is a pediatric neurologist from Universidad de Antioquia and Universidad del Rosario. She currently works at International Hospital of Colombia, Fundación Cardiovascular. She attends our pediatric patients and all the population in general. After Norma's presentation, we have a brief QA session, hopefully. Good morning, everyone. Almost good afternoon here in Colombia. Thanks for your presence in this important symposium. Um, Give me a minute to share my screen. Here we go. You can see it. Yes, Norma, we can see it perfectly. Okay, I'm very grateful for being invited to this event, and I want to congratulate you all because this Promesa project, I believe, is a pioneer in this country and will have an impact on the survival of children and their quality of life in children with complex cardiopathies. My lecture is called Guidance to Improve Neurodevelopment of a Child Facing the Challenge of a Cardiopathy. What should we do? So first, I would like to make an introduction on neurological alterations in children with complex cardiopathies, the prevalence of neurodevelopment disorders in children with complex cardiopathies, the stages of neurodevelopment that can be affected, and finally some data about the detection, follow-up, and management of neurodevelopment disorders in these patients. So having a congenital heart disease, particularly if it is complex, it implies the risk of adverse results in neurodevelopment. So as we have seen in all the presentations, we need to be very attentive to the advance or the progress of neurodevelopment. And in this task, the parents are very important. In this graphic, we see the prevalence of neurodevelopment disorders, either mild, moderate, or severe, according to the severity of congenital heart disease. So we can see how the heart diseases, where there are mild, the prevalence of neurodevelopment disorders is low, while in those severe heart diseases, such as the ones we mentioned today, these disorders may reach up to 50%. In the column with palliated neonates, I want to highlight that neonates with complex CHDs requiring palliative surgery within the first days or months of life have a high risk of neurological injuries given the immaturity that the brain has, and when they are subject to complex surgeries and cardiopulmonary bypass. And the last column shows children with CHDs that also have genetic syndromes, for instance, Down syndrome, where severity and the prevalence of neurodevelopment disorders may reach up to 90%. So, to discuss physiopathology of neurological alterations in CHD children, I will refer to the term coined by Volpe in 2014, which is encephalopathy of congenital heart disease. This term groups all neurological abnormalities, both structural and functional, in children with complex CHDs with regards to the delay in intrauterine cerebral development, cerebral malformations, and new lesions that appear intra or post surgically. The physiopathological mechanisms for these brain injuries before surgery have to do with the alterations in the blood type, brain blood type, as cardiologists have mentioned before, and hypoxemia, because many of these complex CHDs have also failure in brain self-regulation mechanisms. This brain is less reactive to CO2 and the blood vessels. I mean, so these physiopathology mechanisms can reach even to the last quarter of pregnancy, to the reduction of brain volume both on the white matter and the gray matter, and in significant immaturity of the white matter. So to highlight this item of immaturity of of white matter, I want to show this MRI on the screen, where on the left you see an MRI of a preterm neonate, 30 weeks gestational age, with some injuries, uh, hyperintense lesions, which are these white spots on the white matter, the periventricular white blood, which is called enteropathy, ventricular enteropathy, sorry, which is frequent in preterms. And I want to compare it to the right side MRI, where we have the same sequence in a child, a newly born term, on the fourth day of life before a transposition of the great arteries before cardiac surgery, where we see the injuries, which are hyperintense lesions on the white matter, are also present, and they are even very similar to the preterm neonate, and they occur in a late manner because on this diffusion sequence there is a decrease on the diffusion map. So with this, I want to highlight something mentioned by Dr. Duran before, which is the brain of children in complex CHDs is very susceptible to lesions, predominantly on the white matter, and a neonate born on term with CHD, the brain is recoverable in preterm of 36 weeks. And children with complex CHDs before surgery have about 20 to 50% of lesions in the white matter. With regards to the gray matter, there is a decrease. There is a decrease in the chirification or in the complexification of the cortical structure as such, and therefore there is alteration of the synaptogenesis, which is like the brain maturity process at the end of the gestation, and the establishment of the cortical networks. We also see a lot in the clinical practice in the ICU of the Cardiovascular Foundation that children have microcephaly in 10 to 18% at the time of birth. Then, what are the areas of neurodevelopment that are affected in children with complex CHDs corrected surgically? There are several areas. We have the executive function, which is important more than IQ for learning and academic success or school success. And that includes attention, impulse control, self-regulation, planning, working memory, and flexibility, cognitive flexibility. We also have the category for cognition, which will discuss later on, the adaptive function. The adaptive function means the application of capabilities, behaviors, and skills which are necessary for the daily living. That is to say, that allow the child to adapt to the society and its surroundings and to function as a person, as an autonomous person. We have the language and speech aspects and the motor aspect, the development of fine and gross motor skills and visual spatial integration, and a very significant aspect which is the neuropsychological and behavioral aspects, which we will discuss later on as well. With regards to motor development, so with regards with motor development, we will say that children with complex CHDs have a risk of motor disability, but the severe category is infrequent. There has been a prevalence of 30 to 50% of motor difficulties and coordination in those children that may have ischemic CVAs, may have great difficulties in the motor aspect, for instance, having hemiplegia or sensory deficits. Now, on the right side of the slide, considering we are talking to parents and to treating physicians, what are the red flags with regards to motor development within the first year of life? I want to mention this because of all the neurodevelopment alterations, the more visible is the motor development disorder. We have a red flag, the poor head support at 4 months, incapacity of sitting at 10 months, the absence of gait at 18 months, persistence of tiptoe walking after 2 years of age. And then there are other guidelines on motor development, but I want to highlight this because they occur within the first year of life. In the language area, there is a prevalence in children with complex CHDs of 20 to 40% prevalence of language disorders in preschoolers. They are of an expressive and articulation type. So these children will require a lot of support from the speech and audiology therapy, particularly those who have a history of suction deglution disorder. And language is intimately linked, so it is to audition, to hearing. So it's important to have a good screening for hearing function in a group of children with congenital with CHDs or children with Charles syndrome or deletion syndrome, or children that have been in ECMO therapy. So there has been observed a larger incidence. In Colombia, the Colombian practical guideline for the early detection of disorders in neurodevelopment recommend a hearing screening in younger than 3 years of age in instrumental manner, either with auditive without potential or autoacoustic emissions, and in children between the ages of 3 and 5, A formal audiology test is recommended in the detection of hearing disorders. The parents and the teachers are key because they are the ones who first can perceive or realize these deficiencies. Now, with regards to cognition, children with complex CHDs, uh, because of what we have already mentioned before, can have a prevalence between 20 to 50% of learning difficulties, particularly those with cyanizing CHDs. It has been seen that the average intellectual quotient can range between 91 to 95, which is found within the normal average, but with children with single ventricle cardiopathies, this average score can be decreased in 10 points. So 50% of children with complex CHDs may require the early educational support, and some of them require special education support full time, which may represent up to 15% of those patients. With regards to behavior and socializing alterations, those are the alterations in neurodevelopment in the most common CHDs, and this is something we need to explore more carefully. And sometimes we see the most evident things, for instance, motor skills, but this is worth to analyze. These disorders lead risk in the development of communication and the decrease in social skills for the kids. Studies have seen that there is a prevalence in behavior disorders of up to 20 to 40% in children with complex CHDs, especially in adolescents or teenagers with palliative surgeries, as described previously, at a prevalence between 15 to 25% of depression and anxiety, alterations in social perception, aggressiveness, somatization. There are two alterations in neurodevelopment or diseases associated to altered neurodevelopment in the social stage, which is the hyperactivity and attention disorder, which is more prevalent in children with CHDs, with a 40 to 50% incidence, and autism, which is also more prevalent, particularly in patients with 22q11 deletion syndrome, which may reach up to 20 to 40%. These children may have some autistic traits, and it has to do with the difficulty with the theory of the mind. The theory of the mind refers to the inability to evaluate and interpret the mental status of another person, and alexithymia, which is the difficulty to comprehend and describe their own emotions. So in these neurobehavioral disorders, we have a full spectrum. So it is recommended that all children, particularly children with complex CHDs, have an autism screening between the ages of 18 to 24 months. There are several tools, but the most commonly used and validated is the MChat, which consists of 20 questions solved, answered by the questions. The scores are added, and the risk for autism is assessed. I wanted to show this document from the American Heart Association, which summarizes many of these aspects of outcomes in neurodevelopment in children with CHDs, their assessment and their management. This was published in 2012 in the Circulation Journal, where there a detection algorithm is stated in the management of children with complex CHDs. They propose a clinical algorithm which is rather simple and logical, where they recommend to have a complete clinical history to make individualized or customized follow-up in accordance to the risk stratification, to have a proper referral and in a relevant manner to subspecialties and specialized centers when there are neurodevelopmental alterations on the children, and to have early interventions. For the categorization of risk for neurodevelopment disorders in children with complex CHDs, we can see they sort children in low risk and high risk, where high risk are the CHDs, which are mild, simple, such as a CIV, where follow-up for neurodevelopment of these children is made based on the AAP guidelines, which are applied to the general population, and the high risk, which I will mention, where we need to consider neonates or infants requiring open heart surgery or early in their infancy. I mean, children with other cyanotic heart lesions not requiring open heart surgery during the neonatal or infant period, or any combination of a CHD and of the comorbidities listed, which are prematurity, developmental delay recognized in infancy, suspected genetic abnormality or syndrome, as mentioned before, associated to neurodevelopment disorder, the history of a mechanical support, ECMO or VAD, heart transplantation, uh, needing cardiopulmonary resuscitation at any point, prolonged hospitalization. This is related to the severity of the CHD and the need for surgical support. So hospitalization of more than 2 weeks has a higher risk and long term of neurodevelopment disorder. Perioperative seizures, which is overly important, has been said that on the long term this may be a factor leading to ND alterations, significant abnormalities or neuroimaging or microcephaly, and other conditions determined at the discretion of the medical care providers. The American Heart Association recommends that children characterized as high risk for neurodevelopment disorders must be assessed from 12 to 24 months, or from 3 to 5 years, and from 11 to 12 years of age at any time. In Colombia, there are no policies or particular detection plans for children with a special condition such as CHDs. The practice, the practice guidelines from the Ministry of Health for the detection of development disorders in children up to the 10 years of age recommends a frequent follow-up up to 2 years and a half, as described in the here on the slide, and then after the age of 10. However, sorry, up to the age of 10. However, some groups are not considered. They don't consider the groups of children younger than 5 years of age with no conditions that alter their development, such as neurological diseases or any perinatal period diseases, genetical syndromes, or pathologies that alter the neurology development. This will occur in a CHD patient. So to wrap up on this topic, and particularly my call to the parents for children with complex CHD, despite their frailty, we need to avoid the overprotection on these children, because this will limit aspects such as independence. It will undermine their self-esteem. We need to avoid unnecessary restriction. We need to favor both individual and social activities that favor their personal growth. We need to have and appropriate nutrition, which has been widely discussed this morning, also favor the provision of micronutrients, favor physical activity, even though some of them have a heart failure. We should not limit physical activity because these patients, we also require the support of physical therapy or physical or certified trainers, but the idea is that the child is not sedentary. And something which is very important is schooling. Sometimes the overprotection makes or parents avoid sending their kids to school because they don't want them to be in contact with the educational environment. However, this is necessary. So as a support data in Colombia, there is a rule or a legislation by means of Decree 1421 of 2017, by which the Minister of Education regulates the inclusive education in children with disabilities. The intention is for both public and private educational institutions in the country accept children with special needs. This with the idea that education adapts to the child and not to adapt the child to the education. So in order to well, one of the aspects that is and that is addressed in the Promesa project is the surveillance of neurodevelopment, particularly in early detection, to be able to have the therapies and the proper follow-up to avoid stagnation, so to say, or limitations in the quality of life for these patients. Well, so with this, I want to conclude. So thank you very much for your attention and your kind invitation. Thank you, Norma, for your lecture. Very interesting topic. This is perhaps the outcome that we all strive for, to have a proper neurodevelopment, to have a proper influence in the quality of life so they can contribute in the future to the society. We are going to have now a brief Q&A session. We are in a more relaxed manner. There is a question for Dr. Silver. And the question is, sorry, what is the criterion for evaluating the heart? I'm sorry. Gracias, Lali. Esta es una muy buena pregunta. En las resonancias permiten una evaluación no invasiva del paciente y ciertamente tiene un precio. Ahora pensamos que con estas imágenes, al igual que el cambio del área, pues, se pueden tener instrumentos para medir la función por medio de ecocardiografía, pero si tienen las facilidades para hacer resonancias o tomar resonancias y tienen y pueden aplicarla durante la evaluación funcional, eso es claramente una buena herramienta, asumiendo que la evaluación con ultrasonido es una de las, perdón, yo no hago resonancias personalmente, pero tengo colegas que hacen ese trabajo, pues, con bastante experticia. Bueno, yo quería adicionar y preguntarle a Alejandro Washington, ¿cuáles son su uso actual de la resonancia para la evaluación del ventrículo derecho en este tipo de pacientes? Bueno, Javier, gracias. Yo estoy de acuerdo completamente con el doctor Silverman. Ah, tengo que agradecerle personalmente. No nos conocemos, pero hemos utilizado su libro de texto por muchos años. Ah, y aún lo encuentro muy útil. Eh, yo solo quiero sacar mi sesgo hacia la tecnología de ultrasonido, pero es una tecnología pues excelente y muy elegante, pero tiene la ventaja de ser portátil, pero en ocasiones eh, eh, los, uno puede repetir los estudios de imagenología tanto como se necesite para confirmar ese diagnóstico inicial. Al decir esto, la resonancia toma un rol más preponderante para evaluar la función y también a medida que pasan los años y estos pacientes, especialmente los de síndrome de corazón izquierdo hipoplástico, uh, algunos de ellos una proporción significativa presentan fallas, ya sea por disfunción ventricular o, o por falla general del Fontán. Yo creo que la resonancia se vuelve crecientemente importante. Aún no sabemos el mayor impacto que esta tecnología va a tener en la evaluar y el pronóstico de falla temprana, pero creo que se va a volver muy importante. No va a sustituir la ecocardiografía, va a ser complementaria siempre y cuando, eh, mientras no tengamos resonancias portátiles, por ejemplo, los que veíamos en las películas de Viaje a las Estrellas. Una vez que tengamos esos aparatos portátiles para hacer resonancias, van a seguir siendo algo complementario y debemos seguir eh, usar la resonancia para evaluar la función, el mejoramiento de la longitud del pericardio para signos tempranos de fibrosis. Es decir, hemos estado persiguiendo el análisis vectorial y la imagen y la observación de imágenes de distintos modos, algo que puede volverse más importante, pero que también tiene competencia de eco 3D es la capacidad de desarrollar modelos en 3D y modelos computacionales para individualizar o hacer a la medida, por decirlo así, este proceso Fontán o el mejor conducto y eventualmente imprimir con impresión 3D conductos atrioventriculares o conductos Fontan para pacientes que han estado en hemodinamia. Y esto pues está un poco lejano, pero eso es lo que perseguiría la tecnología, diría yo. Gracias. Thanks, Alejandro, for your answer. Uh, yes, actually, ECHO is still a fundamental tool to assess the patient's economic rapid. Clearly, it requires training, but we are seeing that every day it becomes a day-to-day tool, day-to-day use, and it's actually becoming what we back in the day was a stethoscope for all physicians, and I refer particularly to ultrasound technology. We have some additional questions for our guest, for Kevin. Well, there is a question for Vanessa and Kevin. When they mentioned comfort, the question is what other measures can be taken in order to have comfort for children in pediatric cardiovascular intensive care? Well, if we meet 2 or 3 measures, the comfort and well-being of babies change a lot. If we are forced to use respirators that make a lot of noise, for instance, high frequency, there are devices that we can place on the ears to reduce the noise, the decibel levels. We also have uh, the device I showed with that shows with a green indicator when the noise is low, and when red when the noise is higher. So we realize that we are being noisy, and that uh, and with these devices we could improve discomfort luminosity as well. We try to have to dim luminosity on the devices as much as possible. Just like these 2 measures, the comfort for the baby can change significantly. So, from the nursing standpoint, Kevin, what can they do to improve the comfort for these patients? Are there any measures to help them go through this period in the intensive care units? No, no. Kevin, si tú nos pudieras comentar algunas medidas sobre cómo mejorar el confort desde el punto de vista de enfermería. Bueno, yo pienso que, ay no, uno puede trabajar con la luminosidad, estoy de acuerdo con eso. También creo que es posible, eh, ay no, perdón. Solo quiero adicionar un corolario a lo que dijo Alejandro sobre la resonancia. Ciertamente en el interestadio, antes de los shunts, de los, eh, de los shunts Glenn, antes de Fontan, es claramente un lugar para tener resonancia, para buscar en las arterias, revisar las arterias pulmonares y también en el cleavage. Estos son lugares en los que las resonancias y las tomografías pueden tener lugar en una evaluación. Gracias, Norman. Maravillosa contribución. Tenemos tiempo para una última pregunta para el doctor Alejandro. Claudia, por favor. Bueno, we have a question asked to Alejandro. How do you do quality control on the hospital, the in-hospital attention process in your group in the national hospital? How much is the morbidity mortality can you have in the internal control? How do you do this process for management and teamwork between those of you who are face to face over there and those who are monitoring in the distance? Thank you, Claudia, for your question. It is important to say that virtual telemedicine interventions in the CICU and the PICU are traditionally described as complex interventions in complex systems. What I mean is that generally these are interventions that we applied at the same time in parallel or in multiple locations. So assigning a relationship or studying cause-effect relationships in the traditional manner as have been used in other types of quality or research projects is not easy. It hasn't been easy to replicate that. However, it is an interesting area for research, which is the participation in quality processes. How much can the department determine in the hospital or in the division with critical heart patients in order to incorporate them to many of those interventions having only a single phase, so to say. So ultimately what we want to have is a decrease of hazardous events or complications, that there is an improvement in the quality of our patients reflected on the survival and their quality of life. So who takes the medals? I believe it should be the whole team. How and when can we define what telemedicine contributes in all of this? I believe we need to define first the questions or that are more feasible to measure with other tools. For instance, the ones used in disciplines such as anthropology, and define changes in behavior. If you remember, we published some 2 years ago our joint experience between Fundación Cardiovascular de Colombia and our institution, our experience in what we observed in ECMO, in pediatric ECMO program. So what we were able to describe without necessarily assigning causality, but a temporary relationship, the initiation of our intervention and where we accompanied you virtually, and the change of behavior and attitudes in the team, which was also reflected at the same time in a dramatic increase of survival in the ECMO program patients. And I don't have to repeat this to you because you have become a center. We actually say it when we talk about this study. We mentioned this actually. We talk about Fundación Cardiovascular has become a reference regional center, not only national in Colombia, but for all the Latin American and Caribbean region around Colombia. It has become a leader in its internationally in the promotion and development of mechanical cardiopulmonary support in children. And this not only within 5 years. We are talking about that this is a reflection of a massive shift of behavior and attitude in the team that was reflected in an increase, a very significant increase in the performance. That's what I can say. Another kind of things that are important to, it's important to include the perception of the team. The communication challenge is important to be measured and followed up. As perhaps you have perceived it from one side, it is difficult. We talk about control tower and expert pilots in the 30s and 40s. So perhaps that happens to everyone. When we are leading these operations, when we are doing these operations in our own hospital, we are a little bit with one foot in, one foot out. The feeling is not that different from what we would expect to experience in remote institutions such as the Fundación. In our own hospital, the team, the virtual team, one of the most important challenges is to be incorporated into the team and be perceived as part of the team and not as a virtual auditor or having a hostile feeling. So they are collaborators, and as these better outcomes reflect, that's most important. Not necessarily that we offer things in a clinical standpoint. This is not a competition. This is a collaborative challenge for which in which we are privileged to participate in the last 10 years. So we are developing the best models yet and the best measurements to gauge impact. This is an ongoing work. But in summary, by cooperating in quality measurements in which we are part of a series of interventions, some of them virtual, others face-to-face, the struggle to attribute causality is not considering the reality of our interventions and finding alternative methods such as techniques in anthropology, for instance, to investigate the organization of these teams, how they cooperate, what are the factors associated to successful teams, and how the communication improves between the virtual, and the face-to-face teams. Thank you, Alejandro. Thank you very much. You are definitely the pioneers in this. You carry the baton on this, and I believe the pandemic has made the process that you have advanced before allowed for a quick reaction and everything that you showed in your presentation. So ultimately, communication is not only important for virtuality, but also for teamwork, which is necessary in our day-to-day work. So this is our challenge. So I agree with you, Claudia and Javier. It was a great pleasure for me to greet you today and see you. Alejandro, for Norman, Kevin, Vanessa, Norma, Maria, and Dr. Castillo, Dr. Alvaro Duran, Claudia, our colleague and co-worker, Maria Constanza, for Anderson, Carla Castillo, our nurse, Paula Perez, Ana Fernanda, and Claudia Bueno, the psychologist, and the staff at the Universidad Pontificia Bolivariana, Fundación Cardiovascular and Conciencias, now the Ministry of Science, who gave us the support to create this project, and we want to continue with the project. Now we invite you to write to our email, promesaencasa@gmail.com. I invite you also to visit Dr. Silverman's website, where he has his anatomical and echocardiographical correlations. Norman was a professor from us. We have studied from his textbooks, so it was an honor to have him today with us. Hopefully, if the pandemic improves, we hope to see you here in person. Norman, Kevin, Vanessa, we hope for you to visit us. But by now, we can take advantage of virtuality. Now I want to give the floor to Dr. Victor Raúl Castillo, the chairman of the Fundación Cardiovascular of Colombia, who will close this event. And thank you very much to all for your presence. Good afternoon from Colombia already. Thank you very much, Javier. I want to thank first all the professors Alejandro and all the team, all the doctors and nurses that participated in this symposium. I really enjoyed this. I believe this was a very important work. Also to congratulate the pediatric team for the Promesa project. I believe we're having good progress, and in fact, we want to implement it to and strengthen it. And with this virtual group, we want to make this a permanent reality, not only for children with cardiopathies, but with other conditions. And again, my thanks to Alejandro. Very nice to see you here. And hopefully, after the pandemic, I have a trip pending to Washington for a while. Ricardo had invited me and has told me oftentimes to go. But during this stage, we hopefully will overcome it and we'll be able to see each other in person. So thank you to all the attendants. And even after this years as a physician, I learned new things, and I believe we are all pleased with all the breakthroughs in this type of work. So have a good afternoon, and we appreciate your attendance. And many thanks to all of our guest speakers. I wish you the best of luck and have a very nice weekend. Thank you all. Thank you all. Goodbye.